We would like to welcome all of you to the certificate course on medical disorders in pregnancy, which will be held from 22nd June to 22, 23, and 24th of June. We'd like to welcome Dr. Rishikesh Pai, Dr. Madhuri Patel, Dr. Lakshmi. Nilima, please mute yourself. Nilima, mute yourself. Dr. Lakshmi Shrikande, the chairperson of the ICOG, Dr. Parag Biniwale, the vice chairperson, the convener, Dr. Sneha Buver, the co-conveners, Dr. Pratik Tambe and Dr. Mala Srivatsa, the coordinators, Dr. Supriya Jaiswal, Dr. Priyanka Roy, and Dr. Raki Singh, all the esteemed faculties who joined today and who are going to give their valuable time for the certificate course, as well as the delegates who always join in great numbers for these certificate courses. May I now request Dr. Supriya to help in playing the prayer song, please.
Very good evening to everyone. Thank you so much. So before any auspicious event, anything, we pray to the Almighty and seek His blessings. So may I request for the prayer song? No sound is coming.
It's okay. I think Nilima will start. You can stop that.
Okay.
Yeah. You can stop sharing. Huh?
Yeah.
Thank you so much. Now it's my honor to introduce the delegates for. I'm sorry, one second. I would like to welcome Dr. Rishikesh Pai, the president of FOGSI for 2022-23. He's the founder and medical director of Bloom IVF Group and is the chief administrator of the FOGSI Manyata projects. He's won several awards and he's heading several organizations and he's held several positions in the past. I'd also like to welcome Dr. Madhuri Patel, the Secretary General of FOGSI, who was a former committee member of FIGO preterm birth, as well as she was the Associate Director of Journal of Obstetrics and Gynaecology of India. I'd like to welcome Madam for this program. I'd like to welcome the chairperson of ICOG, who's the brain behind the certificate courses for this year, which are running so successfully. And last time we had a registration of almost 500 to 600 members joining in for the certificate course, and we hope we touch those numbers now. Dr. Lakshmi Shrikande is the chairperson of ICOG for 22-23, national corresponding editor of the Journal of Obstetrics and Gynaecology of India, JOGI. She's holding several positions in several important organizations of national and international areas. And it's my honor to welcome Dr. Parag Biniwale, the vice chair of ICOG for this year. He's a senior consultant from Pune, a PG teacher and unit head Kamala Nehru Hospital. He's the president of the Pune OBGYN Society, and he's also the president of the Menopause Society of Pune in 2018 to 22. May I request Dr. Parag to bless the gathering before we start?
Thank you, Charmila. I am speaking on behalf of Dr. Lakshmi Shrikande and myself. Dr. Lakshmi has joined, but she's traveling in UK and then she won't be able to speak. I welcome the Secretary General, Dr. Madhuri Patel, for the programs. And of course, I can see a galaxy of speakers, especially the people who are responsible for the gestosis chapter of India today. Welcome Dr. Suchitra Pandit, past president of FOGSI, Dr. P.K. Shah, past president of FOGSI, and of course, Dr. Gorakh Mandrupkar, who is the Secretary General of India chapter of gestosis. ICOG has, for last 3 years, started with the certification course, and I must thank the COVID times, because until the COVID was here, we never thought of these programs, but during COVID, we all started these activities and continue to do so, and we are trying to do our bit to educate and refresh knowledge of our members. I welcome Dr. Rishikesh Pai, president of FOGSI, who's here. I think, Charmila, let's request Dr. Pai and Dr. Patel to speak first now.
Yes, sir. Yes. Dr. Rishikesh Pai, sir, can you unmute yourself and address the gathering, please? So you have to unmute. Yes, sir. Yes.
Can you hear me?
Yes, sir.
Hello. Can
Yes,
you
sir.
hear me?
Yes, sir, we can hear.
Good
Yeah.
evening, sir.
Hi, so congratulations, Sneha, and all of you for this ICOG online course. Dr. Lakshmi Shikande, Dr. Ashok, and Parag are doing a great job, and the college is having a lot of performance, and there are a lot of people. Sneha is there, Supriya, Charmila, Vidya is there, and Suchitra Pandit, Dr. Pikesha, of course, our Secretary General, Dr. Madhuri, Dr. Mala is there from Delhi, and Dr. Vijaya is there, and sir, as Dr. Sanjay Gupta sir, and all of you are. There are many others. Sorry, I can't see all of them because I'm on my mobile phone and I have a problem with my glasses as well. So please excuse me. Just to summarize that we have come to the halfway mark. 7 months are over and 12 conferences are done. And God knows how many things I have done in this 7 months, and 6.5 months are remaining. There are 11 or 12 more conferences. The Gestosis conference is just around the corner. Dr. Suchitra is busy doing it actively. And I would request all of you to attend that conference if you can. And then, we have the Suffolk conference also is a landmark conference that is coming up. There's a Delhi conference. There are 3-4 specialty conferences that are there, and 4 vice president conferences are also still remaining. And we have the November conference, which is our flagship conference. Every year the president used to have a conference in November, December. So in the olden days, only the 4 UVAs were there, and the presidential conference and the EICOG. Then all these additional conferences started piling up. So this way, I expect that all of you will be there in the specialty conference, and that is from 24 to 26 November, which I'm doing the president conference, and that is in our Reliance Convention Center, the Geo Center, and I'm using a lot of new ideas which I've gained from abroad. There'll be some parallel meetings as well, and I'm bringing in high tech this time. A lot of tech companies will be participating. A lot of other, associations will be participating. I'm planning to give a lot of sections to the chairmen and some of the state associations also. So, thinking of a more parallel out of the box conference, which will be the prelude to the main AICOG in 2025 in Mumbai. I'm the scientific chair of that conference, and we expect around 10-12,000 people. That will be our largest. The last AICOG we did in Mumbai, we had 12,000 people. So this AICOG, that was in 2013. So this AICOG, I expect 12 to 15,000 people. So if provided it is, because now, in my campaign for the trustee of the FIGO, there are a lot of people who are standing for the FIGO trustee. It doesn't really matter to us, because when we reach our peak, when we achieve the peak of the FOGSI presidency. But in the campaign, I feel that word is borderless. And so you have to see, we are educated people. We are not slum dwellers. They are also quite educated. We have to decide whether our education has made us relevant or not. So my philosophy is that word is one, and the fight is between ability and alignment. Will you vote for people who are able, or you will vote for people who are aligned? This is a fight of philosophy. This is a fight. You have to understand this fight. And if we as educated people start voting for alignment, it is a shame on our education. I feel it's a shame. You must vote for ability. Anywhere in your life, vote for ability. Yes, there is something called loyalty also. If someone has helped you in the past, yes, that will definitely feature in your decision to vote in any election. But overall, you should always vote for ability, not for alignment. अरे तू मेरा भाई है, तू अपना दोस्त है, चल हम दोनों मिलके इसको हराएंगे. No, that goes against the basic tenets of intellectual individuals. We are intellectual. We should set the pace for what others should follow. So I really believe in that, and I really fervently, and this is the fight. I'm going to fight this election in Cape Town for the presidency, and I'll fight it on the basis of ability and not on alignment. Just because some are black, some are white, some are brown, some are from Africa, some are from the continent, some are religious, some are Muslim, some are Hindu, some are Catholic. That barrier, if we as intelligent people, if we don't break those barriers, we will never progress. The world will never progress. The world will go into chaos. and we should set that example. So this is what is my fight. Even if I lose fighting this fight, I don't care, but I will fight for that principle from now on. I've decided. I was in the plane. I said, I will fight this battle on the principle. Others will create a new FIGO. I'll create a new FIGO where there is no barriers as far as all these countries are concerned. There should be no barrier. So I would like to thank you all for calling me here for this wonderful program. See, this is knowledge. There is no barrier in knowledge. We must take that philosophy to our life as well. So thank you very much for calling me here and wish you the very best.
Thank you so much, sir. Passionate as ever and from the heart. I'd like to thank you for sparing your valuable time and for your guidance for the ICOG activities always. I now request Dr. Madhuri Patel, the Secretary General of FOGSI, to bless the gathering.
Thank you, Shamila and Parag and Lakshmi, for your kind words and inviting me over here. Of course, Rishikesh is our president and ICOG president also. So respected Dr. Rishikesh Pai, our president, most dynamic and visionary, and he has talked about his vision for not only for the FOGSI president post, but also for the further, the other international organization. And I have come, we have working together since last 7 months, and he's doing fantastic work. And we have many other things lined up, so I really congratulate Rishikesh for the same. Then we have Dr. Lakshmi Srikhande, ICOG chair. As all of us are aware that we have 2 academic wings, and ICOG academic wing is doing excellent work. Even the Jogi is doing very good work. I must say, since the Lakshmi has taken over, she has done so many certificate courses, and this is a 7th certificate course she's doing. And so many, she's really every week, she's occupied, and she make others also to occupy. So that is a very good thing. And Lakshmi and myself are working. Sir, I must tell to Dr. Sanjay Gupta and Dr. P.K. Shah that we are working together. So if we can have our own college, so Lakshmi and myself are really working towards that. And we require everybody's support for the same, sir. So we are just, we have begun the work, sir. So let's see, it gets the recognized, by the NMC. And then we have Dr. Parag. And Parag, next year you'll have to do lots of work. Once we have started the work, you will have to do lots of work regarding the college. And of course, your other academic activities will continue. And Dr. Ashok Kumar, Secretary. And today we have great quotes. All the speakers are great, but I'm really happy that we are having past president for today's, as a speaker. That is Dr. Sanjay Gupta, Dr. Suchitra Pandit, Dr. P.K. Shah, and Dr. Hema Divakar, along with the other experts. So I'm really, really happy. These are going to be brainstorming, sessions for everybody. And then, of course, I cannot forget Dr. Shamila, who is my student, and she's doing excellent work. Dr. Sneha, who are convener, Dr. Pratik Tambe, Dr. Mala Srivastav, Dr. Supriya, Dr. Priyanku Roy, Dr. Rakhi Singh, and of course Gaurav, then Girija, Dr. Murlidhar Pai, and Priti Kumar, and other panelists are there. Of course, Sarita is moderating along with Shamila. So I am really, and all dear friends, ICOG, people who have joined today, very good evening to all of you. At the outset, I would like to thank organizer for giving me this opportunity. I have already mentioned about ICOG, but I would like to say that this pre-eclampsia and the diabetes are really coming up like anything. And after PPA, after the hemorrhage obstetric, these are the 2 major killers of our mothers. So if we are making aware, we are making sensitized, and the recent update of these subjects can definitely reduce the maternal mortality rate. Last week, we had only PPH conclave in Ahmedabad, and so much innovation, so much of knowledge that PPH is the first leading cause of the maternal mortality. And there are so many innovations were there. I was really impressed. It was 3 days I was there, sir, for the conclave. And how you take the conservatively the placenta accreta syndrome, that is surgical management. That was very impressive, because otherwise we take only as an obstetric hysterectomy. So there is this updation of the knowledge is really going to help all our members and which will save our mothers. So we are really marching now. We are 97 per 100,000 live birth MMR, but we are really marching towards the MMR less than 70 per 100,000 live birth by 2030. And I feel this we will achieve before that, deadline, because many of our states have achieved. Few states are there where we have analyzed and we have to implement a policy along with the government. And FOGSI is playing important role. Everywhere the FOGSI policy making decision in government, FOGSI is always there to give the inputs. And of course, our members of the grassroots level, they are doing excellent work, and that's why we could reduce MMR to 97 per 100,000 level. This week, I don't want to say anything more, but I always quote Nelson Mandela at the end that education is the best weapon. When used, can change the world. So we have to update our, ourselves, use this education and give best to our women. Thank you once again for giving me this opportunity.
Thank you so much, ma'am. And we know that you're extremely busy, but you spared your time and came and gave that guidance. And we're extremely thankful for all the guidance and help and encouragement that you've shown ICOG for its educational activities and otherwise. Thank you so much for joining today. Now we'd go on to the session. I would like to now invite Dr. Sneha Buer, the convener for the program. She was the chairperson of the breast committee of FOGSI, and we know that she's done extremely good work there. And the medical disorders and pregnancy certificate course is totally convened by her with in midst of her problems at home and her election campaigning also. She's running the Sukarta Hospital Maternity Home at Yavatmal. She's a governing council member of ICOG now. She's a chairperson of the AMOGS Medical Disorders Committee, the founder president of Vidarbha ISOPAP, and she's a member of the SAFOG working group on breastfeeding. May I request Dr. Sneha Buer to do a preamble for the course, please.
Yeah. Thank you so much, Dr. Charmila, for that kind introduction. A very good afternoon to each and every one of you, and welcome to this focused FOGSI ICOG online certification course on medical disorders of pregnancy. So at the outset, I would like to welcome the most vibrant visionary FOGSI president, respected Dr. Rishikesh Pai, a very dedicated and innovative ICOG chairperson, Dr. Lakshmi Shikhande, the silent and accomplished person, ICOG Vice Chairperson, Dr. Parag Biniwale, Madam Madhuri Patel, the first woman secretary of FOGSI, Dr. Ashok Kumar, the secretary and series convener, Dr. Charmila Ayaho, or my two co-conveners, Dr. Pratik Tambe and Mala Srivastav, and coordinators, Dr. Supriya Jaiswal Priyankur and Dr. Raki Singh. So at the outset, I just welcome all of you, all the respected faculties, moderators, chairpersons, and all the attendees. A very good afternoon and welcome for this program, which is a 3 days focus course. The day one is hypertensive disorders of pregnancy and hyperglycemia in pregnancy. Day two is for anemia and heart disease during pregnancy. And day three is for febrile illness, sepsis and septic shock, and of course the liver disorders and the remaining medical disorders as well. So thyroid disorders are also covered in this. Hypertension, hemorrhage, and sepsis, as all of you know, these are the three major killers, the direct cause of maternal mortality, which are totally preventable. Of course, heart disease, anemia, diabetes, and other medical disorders, they are contributing to it to a major scale. And as all of you know that how the MMR has come down to 97 currently, the credit goes to all of you. Regular antenatal checkup, early diagnosis, and effective management of high-risk pregnancies have definitely helped improving the outcome of pregnancy, and institutional deliveries have helped in reducing the MMR as well as the perinatal mortality rate. So these are not just rates and ratios. The maternal mortality rates we are talking about, these are women. They have their faces, and which we have witnessed in the face of their distress and despair, agony. So these keep haunting our dreams. So it is a need of the hour not to wait for the mortality or near miss and go ahead with the prediction, prevention, and of course preparedness for whatever you have to face. So for HDP and justosis, we are fortunate enough to have the authorities in the field, respected Dr. Sanjay Gupta, Secretary General of Justice, who will be speaking on the prediction and etiopathogenesis of HDP. Dr. Gorakh Mandrukar will be the man himself who has actually prepared the Android app for HDP justice score, which is the most effective predictive measure, which costs you almost zero rupees, I would say. Madam Suchitra Pandit, who is the president of India chapter of justice, who will guide us and take you through the management of, she will take you through the management of hypertension, which drugs, how much and how. Dr. Girija Wagh, a very dear friend, very accomplished academician. She will be talking about the management of eclampsia, and Dr. Muralidhar Pai, who is the Dean of Sikkim Manipal University, will be speaking on the complications of HDP other than eclampsia. And for second session, we have a very experienced teacher par excellence, my mentor, respected Dr. P.K. Shah sir, who will be speaking on screening for gestational diabetes mellitus. Dr. Preeti Kumar, who is the torchbearer of Safe Motherhood, and she'll be guiding us on hypoglycemic agent in GDM. And of course, Dr. Hema Divakar, Madam herself, the president of DIPSI, will be talking to us. Actually, she'll take us through the obstetric management of HIP. And Dr. Sarita Balerao and Dr. Charmila, I'm sure they will be solving all your queries or difficulties which you all face in day-to-day practice. So I'm sure this program is going to change your approach and improve your confidence, and will definitely help in reducing the maternal mortality. I think, yes, together we can do it. With this, I just thank all of you for joining, and I hand over to Charmila and the coordinator once again. Thank you so much.
Yeah. Now we'll go on to the assessment. Thank you, Sneha, for that wonderful introduction to the course. So this pre-test evaluation, you will be given a set of 30 questions, and you need to attend all the 3 days to get its certificate. And for all the 3 days, it's quite compulsory. We will be putting on a Google link for the MCQs in the chat box. You have to open that. The link will be open for 10 minutes. We request the delegates to maintain silence during that time so that the delegates can answer all the questions. And after that, the link will go off. And then at the end of the day, you will have the post-test again. The same questions will be repeated. You will be required to answer that. And the same thing will happen for the next 2 days. We request that you attend on all the 3 days so that you can get the certificate, and they will be issued within 1 month. And that is the way the assessment will be done. May I now request Neelima to put the link for the pre-test assessment, please. And the timer also once you start.
Yes, Mitali, please do the link. Hello, Mitali.
The link has been put, and please put the timer also, Mitali.
Ma'am, timer start हो गया.
Okay. Just put it on the screen, no, so that people can see.
Yes, ma'am.
Yeah. The link has been there, put up already. You can put it again, so that they see. Mitali, put the link twice, thrice.
Yes,
It will be labeled as day 1 pre-test. Please go to that link and click on, and you will get the questions there. Sneha, is the timer visible to you? I'm not able to see.
No, that's the reason I was about to say that I'm not able to.
Mitali, please put the timer on the screen so that everybody is seeing that.
Exactly. Supriya, request to please set up your timer also.
Yeah, the timer is on now.
Yeah, I can see it now.
Yeah, perfect. Yeah, thank you. 30 seconds to go. I think it's over. You can close the link. No, 16 seconds. You can close the link now.
Yes, yes.
Yeah. The co-conveners for today are Dr. Pratik Tambe and Dr. Mala Srivatsav. Dr. Mala Srivatsav is a senior consultant and professor at Sri Gangaram Hospital, New Delhi, and she is also a governing council member. Pratik Tambe is a past chairperson of the Endocrinology Committee, and he's also a governing council member of ICOG. And I'm extremely happy and honored to introduce Dr. Supriya Jaiswal, who's a coordinator for today. She's a vice president of the Partner Society, and she's presently the chairperson of the Adolescent Health Committee of FOGSI and chief consultant at SM Hospital Partner. May I request Supriya to take over the academic session, please.
Thank you very much. At the outset, I would really like to thank first of all, Dr. Rishikesh Pai sir, President FOGSI, Dr. Lakshmi Shrikhande, who is the chairperson ICOG, Dr. Parag Biniwale, who is the vice chair ICOG, and Dr. Madhuri Patel, Dr. Ashok Kumar sir, and the person behind the show, Dr. Sneha Buyar madam. Thank you for giving me this opportunity to participate and be the coordinator of such an important certification course today. I'd like to thank Dr. Charmila, who is the series convener, and she is really very updated on all these things. So really, I welcome you and thank you. And then also Dr. Pratik Tambe, Dr. Bala Srivastav, and my co-coordinators, Dr. Priyanku Roy and Dr. Rakhi Singh. And I welcome all the dignitaries, all the esteemed speakers, and all the panelists, moderators. Thank you very much. And to begin with, I start with this, like, all knowledge is like money. To be valued, it must circulate. And in circulating, it can increase in quantity and hopefully in value. So let us share knowledge and let us hear the speakers, the learned speakers who are all logged in here for the wonderful program. So I just start with shall I share my screen?
Yes, Supriya, you can.
Yeah. Is it visible?
Yes, Supriya, request to make the introductory part shorter so that our speakers get appropriate time for their talk.
Okay.
All of them are well-known, Supriya. 2 to 3 lines is enough.
Okay. So the first, we have this session on hypertension. One second. So we have, for this session, we have speakers, Dr. Sanjay Gupte, Dr. Gorak Mandurpukar, Dr. Suchitra Pandit, Dr. Girija Bagh, and Dr. Muralidhar Pai sir. So we are starting with the first one, sir. Dr. Sanjay Gupte sir is the first speaker. He is going to speak. Just to formally introduce him, he is the FIGO committee, ethics committee chair.
Okay, can skip that.
He has been awarded effort theory, and sir is a wonderful person, helpful for everyone, and wherever you need, sir is there for each and everything. So, or for all the FOGSians. Sir, over to you for your wonderful presentations.
Thank you. Please let me share my screen.
Yeah, I stop sharing.
Okay, so right. Let me share my screen, and first of all, I really admire everybody, all the ones who can remember and acknowledge all these names. I'm pretty bad at that. So I'll just say that thank you, Lakshmi and Parag and the whole team out there. And I think for having this wonderful thought about the conference. And secondly, I will like to congratulate for a new record that we created for FOGSI online, everybody remaining silent for full 10 minutes. So for FOGSI, it would be a, like today's Guinness Book of World Record, I think. But anyway, the lighter part apart, let's directly move on to the talk of the today. And I'm going to talk about the prediction and etiology of HDP, or rather gestosis, to be correctly named. And so, there are two parts, the prediction and the etiology. I'm going to take a little less time on prediction because Dr. Gorakh, who is following me, is going to tell you all the details about the wonderful gestosis score that we have and how it is becoming more and more effective. So some new thoughts, and the etiology is something that I would like to spend time on. So we know that there is definitely a need for a simpler screening test, which is less complicated and less costly. We of course have SPREE study, which told us that if you add on maternal features, MAP, uterine artery, Doppler, PAPI, and IHF, yes, you get for early onset preeclampsia 81% prediction, but still it is only 43% for late onset preeclampsia. So with all that effort and expense, still we are not going anywhere. So now what we know is prediction is better for early onset than late onset. And so the present consensus on all this is that there is no single effective screening test, and none of the tests proposed till date predict the at-risk population for preeclampsia qualified to recommend it for general population screening. And that's why there is a need of this gestosis score. Of course, I will not go through this score because the details will be given to you by Dr. Gorakh pretty soon after my lecture. But just suffices to see it's a very significant clinical sort of score. And if you maintain that score, it will help you not only predicting gestosis in the patient, but if you count the the actual how many points that the patient get, that will tell you about severity also. And not only that, if you maintain this record, your overall history taking for antenatal care is going to be much, much better. So having said that about gestosis, I'll go to the next indicator that I'm keenly interested in, and that is serum endoglin. And as you can see here, serum endoglin also performs highly, and it's found to be significantly elevated in pregnant women with high risk for preeclampsia than in normotensive pregnancies that as early as 13 weeks. And so it's proving to be a very good single biomarker, which we have been looking for. Now, the question is, how do we get it to the patient? And for that, we have now patented this particular point of care test. It is being, actually validated at under the aegis of ICMR for the whole country, and then it will be made available to eventually to all of us. Another important development in this field is the CFRNA. CFRNA is a non-invasive means of monitoring a mother's risk of specific organ damage, and this the CFRNA changes that are characterized in this study reflects dysfunction in at least 5 organ systems, and which are all important in gestosis. And that's why now CFRNA is from the mother's blood, can tell us in very early stages, not only it can predict gestosis, but it will be able to tell us what is going to be the severity and what is going to be the organ involvement in that particular patient, because we know that this differs in each patient. So now let me go on to the etiopathogenesis directly. And so let's start with why it was called as preeclampsia. We knew that there was, people found that eclampsia was a convulsive disorder known for thousands of years. Then they realized that this convulsive disorder always had hypertension associated with it and proteinuria. And even if the patient did not actually get convulsions, still this was had a very high morbidity and mortality. So because it preceded eclampsia, it was called preeclampsia. So this was just a very non-specific description. The high BP and proteinuria were accidental findings. They're not sensitive, not specific, not even most important pathophysiological prognostic factors. And for 100 years, we labeled that and nothing much in this particular field. And then that's why it became diseases of theory, and every single thing that one could think of, the patients were treated and abused. So it took a lot of time even to simply realize that preeclampsia is not only pregnancy-induced hypertension. But in last 40 years, the things have changed, and we have recognized that as a multisystemic syndrome. And the credit goes to Professor Roberts and Redman mainly. They did a huge amount of work, and as you can see here, they realized that there were endothelial dysfunction was important, inflammatory activation was important, metabolic changes were there, and there was balance of angiogenic and antiogenic factors which was disturbed, and the process of trophoblast became more and more important. The problem was, in spite of all this knowledge, we still cannot treat preeclampsia. What we are doing is only treating the symptoms. So the question remains is, if we know so much about preeclampsia, why haven't we been able to cure it so far? So again, we go back to this wonderful etiology of two-stage process. What does it mean, two-stage? That there is a first stage which is practically unseen, and without symptoms, and that happens at the placental level as the placentation occurs. And then that leads to certain changes in the maternal epithelium, especially vascular epithelium, and which leads to the maternal syndrome, and that is what we call as actually manifest preeclampsia. Now again, this figure is practically from second MBBS. Everybody has looked at and marked up, and we say, oh, there is failed remodeling of placental vasculature. And what we are always told that the remodeling of spiral arteries leads to increased diameter of terminal vessels, and because there is replacement of smooth muscles and sphincter-like action is reduced. So the original conclusion was this remodeling leads to large increase in volume of the flow, but Burton in 2009 pointed out that flow is only increased twofolds, but the velocity of the blood is actually reduced from 1 meter per second to 10 centimeters per second. So failed remodeling in preeclampsia does not really reduce the flow, but it keeps the speed high. So in preeclampsia, the speed of the actually flow is high, and the flow is not really reduced. So we'll keep that in mind. And why that is important, that remodeling depends on trophoblastic invasion, which depends on immunological interaction, and that is where the HLHE antigens also come into play, and that is where the paternal, so-called primary paternity comes into the play, because whatever the paternal antigens that are there in the fetus do matter, and that's why we think that when we know that when the paternity is changed, again the chances of preeclampsia increase. So this inadequate perfusion that we just described leads to many effects: intermittent hypoxia causing oxidative stress, release of anti-angiogenic proteins, for example esprit, activation of inflammation. And here that's where the greater velocity of blood matters, because that causes fragmentation of syncytial trophoblast, leading to more deportation of cells, causing more immune response. So this is how all this falls together. So it's not always reduced perfusion, as we have been saying, but its adequacy is very important. When tropoblastic mass is increased, for example, multiple gestations and hydropic placenta, we have actually increased mass of placentation. There is no reduced placental invasion, there is more placental invasion, but still preeclampsia is in fact severe and early. And that's because it's not reduced perfusion, but it is adequacy of perfusion, which is important. And then that brings us to the second syndrome and maternal syndrome, which is characterized by hypertension and proteinuria and all the other pathological changes. And that is because there is vasoconstriction, activation of coagulation cascade, loss of fluid from the intravascular space. All these are consistent with endothelial dysfunction, which Roberts described in 1989. So again, we come to the question whether inadequate placental perfusion alone, we said, is sufficient for preeclampsia. So again, the answer is no, because even if there is inadequate perfusion, that can lead to infants with FGR, and even in many preterm births, the perfusion is found to be inadequate. So it's not just the placental perfusion or placental invasion which matters, but mother's constitution plays a huge role. So it is again something new we are learning. So maternal diseases, maternal lifestyle, maternal genetics, maternal environment, and normal physiological changes of pregnancy, which are basically inflammatory response changes. All these come together, and that so fetus as well as the mother has a role to play in this. So it implies that inadequate uterine perfusion may not only be insufficient to cause preeclampsia, but may also not be fully necessary in some cases. With a combination of maternal factors and inadequate placental perfusion together determining outcome, preeclampsia could occur with very reduced placental perfusion and almost no maternal contribution, that is early onset preeclampsia, or with minimally reduced perfusion and profoundly abnormal maternal constitution, that is late onset preeclampsia. And that is what exactly it is seen here. If there is sort of less space, what is called as a pod bound placenta at the end of the term, when the placenta keeps on growing, that will cause late onset, while if the placentation is poor because of mainly fetal maternal interaction, it will cause the early onset. This was better model, obviously better explanation, but still was not explanatory to all. And that is because we have to remember that the preeclampsia has diverse clinical presentation. Lab reports are variable in all patients, and maternal populations are variable. And that's why, we have to look at the clinical variability of PE in each single case. And these are various clinical symptoms and signs and presentations that you all know that we get in patients of preeclampsia. So where have we gone wrong? We are not, gone for the recognizing subtypes. Preeclampsia or gestosis is not a single entity at all. It has a subtypes. We are focused only on hypertension and preeclampsia, ignoring variables, trying to fit the available data into a single model, while there should be, actually, we should be able to recognize a subtype. When we look at a patient of preeclampsia, we have to look deeply and find out in which subtype she is fitting, and that's how she is going to progress or deteriorate, or what is going to happen to her. And for that, we first of all have to have awareness and not to assume that all the preeclampsia patients are the same, not to force all data to fit to one model. And we have to look at the data without preconceived ideas. And that's where these now new genetic studies come in. Now this microarray study, which is carried out by the Catherine Levy, gave us set of microarrays in 3-4 different types in placenta of preeclampsia. And there is early onset, microarrays that is different, typical or maternal late onset is different, and immunological is different, and also genetic is different. So this is again something important that the time doesn't permit me to go explanations. But
one more minute, sir.
Yes, exactly, one more minute. So now when we are coming to is the epigenetics of the placental function. So what we are also learning now, that at specific time points in development, which help their expression or suppression, so the genes, the methylation of gene, when it occurs, is going to matter and that is going to take, show us how this gene is going to be expressed. So maternal exposure to severe stressors such as environmental pollutants, nutritional factors, psychological stress, or maternal depression during pregnancy can increase the chances of gestosis in a particular patient. And the latest on this field, of course, if you see again all the newest or recent papers are on microbiome. Now we know that microbiome plays a huge role in all our functions, from our health to cancer to all NCDs. And in pregnancy also, the short chain fatty acid levels changes according to the gut microbiome that we have in all of our guts, and it does change during pregnancy also. And all the new studies are showing that the gut microbiome in preeclampsia patients is entirely different. There is dysbiosis, and this dysbiosis, if we are able to correct, then maybe we may be able to prevent preeclampsia, and we may be able to treat preeclampsia, and so that will give us a good simple handle in managing the preeclampsia. So in summary, this knowledge of existence of preeclampsia subclasses will be key to the generation of robust biomarkers capable of identifying all these groups early in gestation and allow for development and implementation of etiology-based treatments aimed at specific subclasses of this disorder. And epigenetics and microbiome is going to be the final answer in solving this age-old puzzle of gestosis or preeclampsia. Thank you so much for your kind listening.
Thank you. Thank you very much, sir, for wonderful presentation and enlightening everyone on this topic. So now, since we are running late, so we'll switch over to the second talk that I invite Dr. Gorak Mandrupkar. He is going to speak on HDP gestosis score. He was the inventor of gestosis score. So over to you, Dr. Gorak, for your presentation. Your time starts now.
Yes, thank you very much for the opportunity in this prestigious ICOG course, and I'm very much thankful to Dr. Sneha Buyar, Dr. Parag Beniwale sir, Dr. Srikhandi madam. I'm presenting mainly the prediction and prevention of hypertensive disorders, and mainly I will be talking on HDP gestosis score. Just now, sir has given a very beautiful pathophysiology and what's new in understanding this concept of gestosis or the preeclampsia, how it happens. We all know that we do approximately 26 million deliveries per year, and the incidence of HDP is still 10.3%. That means approximately we are doing 2.7 million cases per year. And still there is incidence of eclampsia, which is 1.9%, and approximately 0.5 million cases, they are still there. Even WHO says that 19% of the maternal deaths, they are due to hypertension in pregnancy. So that very clear that there is definite need for early and universal screening. And now we all should stop using the word, the prediction of preeclampsia or prediction of hypertensive disorders, but we must talk like universal screening, because then automatically all those things, they will start. But do you think that it is very easy? So no, because in India, it is very gigantic task to screen all the women. There are altogether so many tests, they are being suggested since our PG days. We all know many of the tests, they have taken exam like anything. The tests which are based on placental perfusion and vascular resistance dysfunction, like rollover, Doppler, platelet calcium response. There are certain tests which depend on fetoplacental unit dysfunction, like histiol, alpha fetoprotein, etc. And so on. So altogether, there are more than 60 tests, but none of them was found to be reliable as a single test. And then everybody, they come to the conclusion, right? Our own FOGSI, Indian College of Gestosis, the good clinical practice recommendations, United States, Australian government department health guideline, NICE guideline, WHO. Everybody, now they have come to the conclusion that clinical risk factor based screening is recommended. So it's very clear that all guidelines, they are not recommending to do all those biomarkers and etc. It's very clear message. This actually stirred a lot. Sir has given a brief idea about this study, that is a SPREE, where they have shown that when we do the screening with maternal factors, MAP, uterine artery, PI, PAPI, and PLGF, we may go up to the 81% detection rate in preterm preeclampsia. But it cannot be a routine screening tool because it was not a proper study, but this is a mere regression analysis that we have to very much understand. It is impractical to apply to every pregnant woman in the general population. And unless until we do that, we cannot have the exact idea. And all guidelines, they have mentioned that we cannot use that. But still, we thought in India, if we do it, then what will be the budget? The budget will be 2,800 crore per year, which will be 1/10 of the total allocation to the National Health Fund. So then in Justice India, we said and we thought, can we simplify the screening? And the answer was yes. And this is how the HDP Justice score came. It is nothing but a simplified, dynamic, feasible quantification of the maternal clinical risk factors for effective screening. In the words of great Dr. Raghunath Mashelkar sir, it is nothing but it is an affordable Indian innovation, and he has given a name to such innovations as innovation. Yes, I was in a key role of the developing it, but it was modified by my PG teacher, Dr. Sanjay Gupte, Dr. Suchitra Pandit, Dr. Alpesh Gandhi, and Dr. Girijabha, and this was accepted in FOGSI ICOG GCPR. What is this scoring system? We all know that there are so many risk factors, and even if you see NICE guidelines, ECOG guidelines, there are mild risk factors, moderate risk factors, and high risk factors. Mild risk factors are those when they are present in combination, more than 2 or 3 when they are in combination, then they will put that lady at risk for preeclampsia. Moderate risk factors are those, again, when they are present in combination, they may lead to that women at risk for preeclampsia in maybe in 10% cases. But high risk factor is one when there is mere presence of one such a high risk factor, and if it is there, the lady is at risk to develop the preeclampsia. So depending upon that, we have identified the risk factors pertaining to our own Indian population. Questionnaire was prepared. Now there is simple app which we can use in 1 minute. That's why I have put the message that please go on Android App Store, Play Store, and just put HDP Justice score, and you will get the app which is free of cost. Here, these are the risk factors. These are the mild risk factors, and we have given quantification as 1 for the mild risk factor. The idea behind that was when they are combined, when they are together, like say for example, when age is older than 35, she is primigravida and she is having polycystic ovary syndrome. Everybody will agree that yes, when these factors combine together, she is at risk to develop the preeclampsia. So these are all mild risk factors which are given score as 1. These are the moderate risk factors. When only 2 moderate risk factors are present, or 1 mild and 1 moderate is present, the lady is at risk to develop preeclampsia. You can agree with me that if there was a primigravida and she is having gestational diabetes mellitus, or a primigravida having family history of preeclampsia, or even multiple pregnancy. So these, when they are combined, the women are at risk to develop preeclampsia. And these are classic 7 factors. When there is only mere presence of one factor, and that will lead to that risk for the preeclampsia, known case of diabetes, chronic hypertension, any mental disorder which will require the treatment, all inherited acquired thrombophilia, maternal CKD, even SLE plus, we all know. And when the IVF, when it is done using either womb donation protocol or surrogacy, that means when the oocytes are, when gametes are from the different partners. So these are the high risk factors. We have to just click when we are using the chart, or we have to just use the app, and in 1 minute, there is a sum total of all the score comes in front of us. And when it is more than or equal to 3, the pregnant woman is marked as at risk for HDP. So our universal screening is over. It's very simple. Can be done by any level of the health worker. Even our ANC, our ANM can do, our ASHA worker can do, our colleagues can do, our doctors, we can do in 1 minute. But it is our duty to mark on ANC paper, inform the woman and relative, and discuss with them about diet, exercise, as well as the prevention strategy at the same time. One line, prevention of HDP, aspirin 75 milligram at bedtime, along with calcium 1 to 1.5 gram in divided doses, low carb, high proteins, no need of salt restriction, but no excess salt. There are certain lines I know where debate can go on. I'm not going in detail, that's not my topic. Scoring system is dynamic because every visit we can have simplified additions. Say, for example, there are certain risk factors which are based on the history, which she may not know, but yes, later on she can tell us, and from that day onwards, we can put that lady as at risk. There is no need to wait till 12 weeks or till 16 weeks as in other systems. Every visit, there is opportunity to reduce the risk because we can start the aspirin right from 6 weeks till 28 weeks. There are 5 risk factors like mean arterial pressure, anemia, GDM, weight gain, and hypothyroidism, which are dynamic factors. And we are saying that ideally this should be seen at commencement of each trimester, and even at that trimester or at that point of time, we can add on this score and we can start the preventive strategy. Are there clinical evidences? Yes, each clinical risk factor has good clinical quality reference. Even there is a beautiful meta-analysis which has comprised 92 studies, 2,53,56,000 patients in 27 countries. They have very well given regarding the risk factor of each and every risk factor. This is app, how it comes. And I'm very proud to say that the score is validated, because when we presented in Pondicherry initially, there was a question that whether there is a validation. Yes, there is a validation. In fact, our score is validated by SPRI itself, because they have said already that maternal factors and MAP that gives almost 40 to 50% detection. Even NICE guidelines, they have given that yes, the clinical risk factors, even RCOG guideline, ACOG guideline, they have said about this. This is a beautiful paper of our own Dr. Meeta Gupta from Jammu. And here 473 pregnant women were studied, and she got sensitivity of 83%, specificity of 97%, positive predictive value of 97, and negative predictive value of 95%. Yes, they very recently, 2023 March, in BJOG it has come. This is a Kolhapur group with Dr. Josna Deshmukh. They have studied and they have come up with sensitivity and specificity more than 95%. This is very recent and our own. A very beautiful study. Again, it was done in Visakhapatnam, and they have come up with the conclusion that justosis score is a novel early marker for prediction of development of preeclampsia, allowing for a prompt management for patients, thereby curbing. And this is something miraculous. This was study done by Symbiosis people, and they have actually studied how the score was developed, which system was developed on justosis score. Myself and Ms. Sima, they were actually on these algorithms, and even AI algorithms, they were also compared, and Symbiosis people, they have come up with a beautiful conclusion that justosis score It's the last slide.
Oh, online talks about
Justosis score is a simple scale that can be administered by all frontline health workers in community without intrusive procedures. Again, this is very recent in February 2023. So, to conclude, I would like to say that please don't go into the high-fi things like biomarkers and uterine artery PI and so many things for screening. I am not against the biomarkers. I am not against the uterine artery PI. But again and again, I am saying that when we are thinking of universal screening, it has to be clinical risk factor based screening. This is not only our opinion. Again, I repeat, ACOG, NICE, RCOG, our World Justice Organization, FOGSI, ICOG, everybody is recommending. Please go on the Android Play Store, just type HDP Justosis score, download the app, put your email ID, you will get each and every report. It gives not only the risk, clinical risk scoring system, but at the same time, it gives the preventive strategy as well as it gives all of us what should be the next step. So I'm thankful to all. Thank you very much for opportunity. I thank ICOG office bearers. Thank all of you. And I'm very much proud to say that I'm presenting all these things in front of our own Justosis team who all were the part in this development of HDP Justosis score. Thank you very much.
Thank you, Dr. Gorak Mandupakar, for a wonderful presentation. So, audience must have benefited lots from your talk. Thank you so much. So, we move ahead. The next speaker is Dr. Suchitra Pandit, Madam. She will talk on antihypertensives, which, when, and how. She is the past president FOGSI and past chairperson AICC RCOG, and she has also initiated FOGSI Justosis hypertensive disorders during pregnancy. So over to you, madam, for your presentation.
Thank you, Supriya. Can I share screen?
Yes, yes, sure.
Is my screen seen?
No, ma'am.
Okay, just a second. Just a second. Okay. Now is it seen?
Yes.
I'm just making it. Is that seen now?
Yes, yes, madam.
Okay, wonderful. Yeah, it's full screen.
No, it is not coming full screen.
Okay, just a second. Let me stop it again and make it full screen again. Share screen. Now is it okay?
Yes, yes,
okay.
Perfect.
Okay, so after those two wonderful talks by Dr. Sanjay Gupte and Dr. Gorak Mandrupkar, here I am going to be talking about antihypertensive drugs, which, when, and how. So I'm sure you've used the Justosis score, you've downloaded the app, and you've already decided that this patient is high predictor for preeclampsia. And then when she develops preeclampsia, what do you do? So we know the definitions of the HDP. I'm not going to talk about it as Sir has already mentioned, but we must understand that preeclampsia is a serious multi-organ complication in pregnant women, which is defined by the new onset of hypertension and proteinuria at 20 weeks of gestation and after. And remember, HDP is second to hemorrhage as a direct cause of maternal death. So again, I'm not going to go into the details of definition, but just wanted to tell you that as per the earlier definition, the newer definitions of preeclampsia say that you don't need proteinuria to diagnose, because many a times you can get hypertension and you can get signs of maternal organ dysfunction even without proteinuria. So therefore, you can have preeclampsia without proteinuria. And therefore, what Dr. Gorak was mentioning is so many varied clinical presentations. So we must have a specific and reliable assessment, and that's where the Justosis score helps. Now, for my practical treatment of hypertension, I must just quickly know about the classification. So non-severe and severe. Non-severe is what is mild to moderate, and severe is BP of 160 or more systolic and 110 or more diastolic. And anything which is less than that is going to be known as non-severe. So these are the various criteria. You can have proteinuria, oliguria, all these things, but the grade of proteinuria and FGR are not significant in determining severity. So what is the aim of any antenatal care? Obviously, first thing is you've got to screen and do a surveillance for preeclampsia. Once you find that there is preeclampsia, aggressively monitor her and treat her, because we want to reduce the morbidity and mortality. Do a fetal surveillance at timely delivery, and 100% there should be no eclampsia at all. In fact, zero eclampsia is what our aim is. So treating hypertension is better for the mother without increasing the risks for the baby, as severe hypertension can lead to adverse maternal and perinatal outcomes. And prevention of development of adverse effects is better. So therefore, the CHIPS trial, all of you all have heard about Laura Meggie and the CHIPS trial. They mentioned that the tight BP control has halved the risk of progression to thrombocytopenia and elevated liver enzymes for the mother. And they do not cause any adverse effects for the fetus or the newborn. So and this was true regardless of the gestational age at which the BP control was instituted. So the important question, which, when, and how. So let's start off before the which, we'll start off with the when. Antihypertensive therapy is recommended for average systolic blood pressure 140 or more and diastolic of 90 or more in pregnant women with chronic hypertension, gestational hypertension, or preeclampsia. And remember, we are not looking at 140, 100 as was the earlier practice. So remember 140, 90 or more. But if you have a diastolic of 85 millimeters of mercury, it should be targeted for the pregnant women who are on antihypertensive therapy. They probably have chronic hypertension or gestational hypertension. So in those cases, you can look at a diastolic BP of 85. A similar target should be considered for pregnant women with preeclampsia. Now, if the patient is already on antihypertensive therapy, then in this case, if the diastolic falls to less than 85, you can reduce the antihypertensive dose, or if you find the diastolic is going further down, you can even stop it. But if the diastolic is more than 85, and this again, we're talking of patients who are already on antihypertensive therapy, then you can increase the dose. And if you have stopped it, you can restart. So this is what the CHIPS trial has said. So why do you actually want to control the blood pressure? We know that severe systolic hypertension is an independent risk factor for stroke. So if you have an isolated BP of 160 by 80, and if you feel that it is persistent, please treat this hypertension. But overall, we are looking at the mean arterial blood pressure of more than 125, a BP of 160, 100. All these are going to be severe preeclampsia. And we want to prevent the cerebrovascular accidents, eclampsias, cardiac failure, and abruptio placentae from the fetal point of view. And I know Dr. Muralidhar Pai is going to be talking about all these, so I'm not going to go into details, but all these complications can be prevented by timely intervention and by correct treatment. So how do you actually manage? Non-severe preeclampsia can be managed expectantly till fetal maturity or 37 weeks of gestation, and also till spontaneous onset of labor if the BP is well controlled. And in between, if you ever have BP rise, a day's hospitalization can be done, or an ambulatory management where you're looking at the BP, fetal evaluation, 24 hours protein, and evaluating any other systemic involvement. What about severe then? Severe, we already know what the definition is. We've already talked about this, but confirm that it is severe and then start off with the treatment. So management of severe preeclampsia is based on the principle that delivery is always appropriate therapy for the mother, but may not be so for the fetus. So if there's a rationale for management other than delivery, it would be to palliate the maternal conditions so that you allow fetal maturation and probably a little bit of cervical ripening. So the management of severe preeclampsia, prompt hospitalization for the safety of the mother and the fetus, IV Maxil to prevent convulsions, antihypertensives to prevent complications, steroids for our lung maturity if preterm, but stabilize the BP and do it, and delivery when appropriate. So we've just mentioned about when to start the antihypertensive therapy, and we have decided 140 by 90 or more as suggested by the ISSHP, by the CHIPS trial, by the World Cystosis Organization, and the choice of the agent will depend on the obstetrician's experience and patient. And I'd like to add one more word over here: the availability of the drug. Correct dosages and rational combinations should be used. And we have to remember that there's a mother and there's a fetus. So impact of changes in metabolism should be considered when choosing a drug. So therefore, that appropriate dosing is important, and avoid hypertension. Prompt, but not fast. So the care plan, this we are all familiar with. If there is less than 25 weeks, you stabilize the patient and terminate the pregnancy. Sometimes it may be 25 to 26. 25 to 33 is expectant management, where you're giving Maxel plus steroids, for the lung maturity, and more than 34 weeks, stabilize and deliver. So which antihypertensives to use? Choice, I've already mentioned, correct dosages and rational combinations. But the first line of therapy is labetalol, nifedipine. Nifedipine can also be given as a first line, but most of the societies now agree that labetalol is a better first line, or sometimes the combinations can be used, but you use the combinations. I will discuss about that just a little later. Alpha methyl dopa is available in UK. Time tested is the only category B antihypertensive, but it is not available in India at most of the places. Nicardipine has joined the armamentarium, and amlodipine, there are some 12 small studies on amlodipine, but right now it is not a part of the recommendations. And drugs which we should not 100% use: diuretics, beta blockers, ACE inhibitors, and atenolol. So if the patient is already on ACE inhibitors or atenolol, please change over to the safer ones, that is labetalol. And the challenges that we must remember is the pathophysiological changes during pregnancy, as Dr. Gupta had mentioned, and these will affect the drug disposition. So they should allow safe continuation of the pregnancy. You must have a predictable response, but not an abrupt fall in BP. Safe to use in non-severe and severe PIH, safe to use in all the trimesters, and suitable as far as fetal-placental blood flow is concerned. So the first drug is labetalol, category C drug, available as oral and IV. Combines both selective competitive alpha-1 adrenergic blocking and non-selective competitive beta adrenergic blocking. And remember that the alpha to beta activity is 1:3. It reduces the peripheral resistance without significantly affecting the maternal cardiac output and pulse rate, causes a dose-dependent fall in BP without a reflex tachycardia, and gives benefit to the mother as well as the fetus, and can be used in both the varieties of hypertension, and 100 and 200 both are available. So this is a chart which again just says what I've already mentioned. So I won't go into the details of that chart once, but remember, it protects the heart from the reflex sympathetic drive. So it doesn't lower the placental and fetal flow, which is very, very important. Spontaneous preterm labor has occurred less with labetalol, does not affect the liver. There's a favorable effect on the renal function, and therefore we do recommend using this particular drug. And as far as fetal outcome is concerned, there are better, beneficial perinatal outcomes. There is in any reports of congenital malformations, if used early, direct beneficial effect on the fetal lung maturation, and doesn't cause clinically important sympathetic blockade in infants who are born to mothers treated with labetalol. And adverse effects, yes, headache, tiredness, lethargic can be there, but remember the contraindications. If the patient has got asthma, cardiogenic shock, if the pulse rate is less than 100, or if there is a hypertension sensitivity, or if there's a second or third degree heart block, please do not use labetalol. All the societies, including our FOGSI and Gystosis, are recommending oral labetalol as a first line of option for the non-urgent and outpatient treatment. But remember, it is a viable initial option even for treating severe hypertension in low resource settings. So these were our FOGSI guidelines, where in 2019 we had said this was the way first line effective and preferred, and we had talked about the contraindication. So now let's talk about nifedipine. Nifedipine is a popular effective calcium channel blocker. It reduces the mean arterial blood pressure and relaxes the arterial smooth muscle. Can be used in both types, can be used in the presence of bradycardia. So where labetalol cannot be used, nifedipine is used, but never give it sublingually. In the UK, you still have the sublingual preparations. You have the slow release and you have the extended release. In India, we have the oral nifedipine, which acts very fast. And the second is the SR, that is sustained release. So the 10 milligrams, if you're giving it in non-severe, 10 milligrams every 4 to 8 hourly, and even severe, 10 milligrams repeated after 30 minutes. And once the BP stabilizes, only then shift to sustained release. The mistake people do is start off with the sustained release. Remember, it will not act. Side effects are obviously headache, very, very common, nausea. And if the patient doesn't respond to it, sometimes the dizziness can be there in CCF. Now, nicardipine is a wonderful drug, which is the same family as nifedipine, was used by the cardiologist for high BP and angina. The advantage is it is more selective for cerebral and coronary blood vessels, 100 times more water soluble than nifedipine. So can be given IV. Onset of action is 5 to 15 minutes and elimination half-life is 8.6 hours. So the oral tablet produces significant decrease in systolic and diastolic. But if you're planning to use it for the emergency purposes, initial infusion rate is 5 milligrams per hour. There's a 10 ml vial available. So every 5 minutes, you give it to a maximum of 30 milligrams per hour till the desired BP is achieved. Now, though alpha-methyl dopa was a drug which we relied on, there were problems of postural hypertension, decreased mental alertness, extrapyramidal signs, but it is not available now. So I'm not going to talk too much about it, but just to remember that it was a centrally acting alpha-2 adrenergic agonist, and therefore it caused that impaired sleep and decreased mental alertness.
1 more minute, ma'am.
Yes, 5 more minutes. Yeah.
One more.
Okay. Just give me 2 minutes, please. So low dose aspirin is not an antihypertensive, but we do use it for prevention of preeclampsia. And as per the Justosis trial, low molecular weight heparin is not an antihypertensive. These are the drugs which are used for emergency. I've already discussed about them. And you can use any regime, Parkland, Cibai, or the ICOG. And hydralazine, just few words about it. Dangerous drug, but a wonderful drug, but it can cause a fall in the BP. Precipitous fall. So be very, very careful when using it. So use it when you've decided to terminate the pregnancy and you're waiting for the anesthetist to come. You can give it very close monitoring, 20 to 40 in 500 ml of 5% dextrose, 2 milligrams per hour. But if you don't use it correctly, it can cause hypertension and tachycardia. So just know the difference between hypertensive crisis that causes end organ complications, hypertensive urgency, there is no end organ complications. But GTN is a drug which can be used, but it causes severe headache, not having a big trial. And sometimes if you use it, it can lead to even fall of BP and suddenly stillbirth. So if you decided to terminate the pregnancy, get a cardiologist involved. And the same way may appear for other antihypertensives which causes sudden cerebral vasodilatation. So remember just one thing, when you're starting the doses, be specific, start off with 200 milligrams of labetalol 3 times a day or 4 times a day. But when you find that after using 4 times a day, it is not helping, please change over to the dose consensus protocol or the dose escalation protocol. So do not keep using one drug over and over again. You can combine labetalol with nifedipine, but never give it at the same time. Put a timing, 7 a.m., 12 a.m., put the timings so that the patient understands. If in the ICU setup, obviously we will control. And the same thing has been reiterated by the Canadian Society. Many trials have shown that labetalol is superior to nifedipine in certain situations. So prevention of seizures is already going to be discussed by Dr. Girija. But just to tell you that magnesium sulfate is not an antihypertensive. It does cause cerebral vasodilatation, can be used prophylactically to prevent eclampsia, and Girija will be talking more about it. So just over to the last important points to remember. You can use combination of drugs, but use them very carefully. Magnesium is not an antihypertensive, and whenever you're using whatever drug, use it very carefully. Prompt but gradual fall. NTG infusion, if you want to use, only in the context of ICU setups. And sodium nitroprusside can be used again in the context of ICU, but not when you're planning to continue the pregnancy. And don't forget to monitor these patients postpartum. Reduce the dose, but do not forget, please call them back, because hypertension can peak even later on. If the hypertension persists beyond 6 weeks, please refer them to the cardiologist and the nephrologist to find the cause, do the renal Dopplers. And care providers, remember, post-traumatic disorder is important. Discuss about contraceptives, and don't allow these patients to get pregnant. Immediately ask them to come for preconception counseling, and watch out for the mental health complications. So remember, treatment of non-severe is still very controversial. So we have given you data, whatever we have, but remember, treating them correctly, appropriately will be the best possible way forward. Thank you very much. Sorry to have stepped over.
Thank you, madam. Thank you for your wonderful presentation. Now we move ahead to the next speaker, who is Dr. Girija. She will be talking on management of eclampsia. She is the Vice President-elect FOGSI. She was also a chairman of Chairperson Medical Disorders in Pregnancy Committee FOGSI 2012 to 16. Over to you, madam. You can share your screen. She was also a member of Governing Council. Madam is a great orator and a wonderful teacher. Let us hear from her. You can share your screen, ma'am.
Okay, thank you so much for that wonderful introduction. And the task that has been given to me today is to speak about eclampsia. And according to me, when this happens, this is something which is completely preventable. And it's not been today, but it's been ages since the FOGSI has been speaking about it, and especially under the presidency of Dr. Sanjay Gupta, when I had the privilege of being the Joint Secretary. Completely say no to eclampsia was something that was eradicating eclampsia was one of the principles, and that took us all across the country to speak about magnesium sulfate. So eclampsia equals to magnesium sulfate is something that I can very confidently say, and that has been a game changer because it has really changed the practice and the management. And thank you for that kind introduction. What we are going to expect in the next few minutes is the definition, the diagnosis and the differential, immediate treatment, pathophysiology, delivery, prevention, and the future management. Now let's understand eclampsia. It's a new onset generalized tonic-clonic seizures or coma in a patient. Remember, coma, sometimes you may not have this classic convulsions. Patients may be just unconscious, and that can be eclampsia. And HELLP syndrome and gestational hypertension can be concurrently present. You may have an HELLP without hypertension. You may have gestational hypertension, which does not have proteinuria, but still you may have patient coming to you with seizures. And therefore, it is important that we understand the potential of these HDPs to finally go into the formation of eclampsia. It's very, very heart-rendering to see such a picture where a woman is brought in, and this woman is just about 21 years of age, and you can see the amount of sickness, the pathologic things that she has around her, which has finally led her this particular malady. So it's characterized by onset of seizures of pregnant women with preeclampsia, and it's a common complication of preeclampsia and can be life-threatening for both the mother and the fetus. And preeclampsia, as we understand, is any hypertension which is associated with proteinuria. Now, despite advances in detection and management of preeclampsia and eclampsia remains a common cause of maternal morbidity and death, especially in resource-limited regions. And this video, which I sent you, is from one of my students' hospitals who practices in the peripheral part of our country. And such kind of events continue to happen in our country. Now, we very wonderfully understood the pathogenesis of this disorder, which is something which starts with hypoxia to begin with, because there is compromised uterine vasculature, giving rise to placental ischemia, giving rise to all kinds of noxious elements inside the body, and finally landing up in causing a multi-organ failure. And therefore, definitely when we understand this pathogenesis, we feel, can we not do early enough something so that it will be prevented? Let us also understand, why do seizures occur? Now, if you look at the mechanism of eclamptic seizures, popular belief is that it is cerebral vasospasm and cerebral edema. But the argument also is that it's not only the reason. The uteroplacental ischemia causes the release of certain molecules such as neurokinin B, inflammatory cytokines, endothelins, and tissue plasminogen activator. And these molecules stimulate excitatory neuronal receptors and alter neuronal excitability, synaptic transmission, and neuronal survival independent of any vascular effect. So therefore, this justosis name seems extremely appropriate, wherein there is a sort of a systemic immunological inflammatory response of the body, which also is going to a condition which is so very grave, increasing the maternal mortality and the morbidity of the woman phenomenally, that is eclamptic seizures. Now, whenever we look at, and the talk after me is going to be by Dr. Muralidhar Pai on complications, but when we are looking at it happens to be one of the CNS complication of the HTP conglomerate of disorders or justosis, as we like to call it. There can be intracranial hemorrhages, infarct, cerebral edema, press, that is posterior reversible encephalopathy syndrome, blindness, seizures of various kinds, focal neurological signs, prolonged coma, atypical or recurrent convulsions and seizures even after delivery. Intracerebral hemorrhage requires immediate reversal of any coagulopathy, as well as the discontinuation of any anticoagulant or antiplatelet therapy if the woman is already taking, and antihypertensive therapy, seizure prophylaxis, and neurosurgical consultation may also be indicated. And we also run a high dependency unit in our center. In at least once in 6 months, we'll end up having a woman who requires a cerebral intervention, surgical intervention for this complication. Now, when we look at risk factors for eclampsia are preeclampsia GHT, Black and Hispanic race, advanced maternal age, nulliparity, maternal age of 20 years or less, even teenagers are at risk, multifetal gestation, preterm delivery at less than 32 weeks due to hypertensive disorder, and lack of proper prenatal care. And that is something which is very, very essential and something which we definitely can modify and have a control on. Now, the several signs and symptoms may precede eclampsia. It's very important to be conscientious about these ones, where visual disturbances, blurry vision, diplopia, scotoma, photoxia, transient cortical blindness can be there. Patient may say, doctor, I'm having epigastric pain, and many times inadvertently they receive antacids or such kind of medicines, or they are told that probably they are hysteric or they are having nausea, vomiting, and they do not get the correct attention that is essential. Severe persistent occipital or frontal headaches. The most common symptoms, if you look in the form of severity, headache is found in nearly 66% of the patients. Visual disturbances, 27%, and right upper quadrant or epigastric pain in about 25% of patients who eventually have eclampsia. Now, eclampsia is the most common, easily identifiable complication, and antepartum is the most commonest, that is about 38 to 53%. Intrapartum also women are at risk, 18 to 36%, and postpartum 11 to 44%. Atypical eclampsia has been also seen occurring before 20 weeks of gestation, especially in multifetal pregnancies. It will be very commonly seen. And there can be convulsions despite adequate magnesium sulfate dosages. Without adequate magnesium sulfate dosages, it's a commonality. And 48 hours postpartum, also called as late postpartum eclampsia, can be an association. So seizures, whenever they occur, should be promptly treated with a bolus of intravenous magnesium sulfate, followed by continuous infusion of magnesium sulfate. This immediate prompt bolus of magnesium sulfate can be a lifesaver. And unfortunately, still many of our colleagues still find it easy to give them diazepam, which is not really something which is recommended. It is very important that you give these patients magnesium sulfate. If there are intractable seizures or resistant eclampsia, in addition, supportive care is essential. If there is intractable seizures, find out, have you really given the right dose? Or maybe then you'll have to use an alternative. And the woman has to have a proper recovery position, bite protection, supplemental oxygen, which are extremely essential. One has to be also aware of differentials, but always remember any kind of seizure in context of pregnancy is always a eclampsia unless and until ruled out. And therefore, epilepsy, syncope, stroke, ICH, hypoglycemia, cerebral malaria can be some of the DDs which we may have to consider. Now, what is PRES? This is a reversible subcortical vasogenic edema that can occur during pregnancy, most often in association with eclampsia. presents with an acute increase in the blood pressure accompanied by headache, seizures, visual deficits, and or an altered sensorium, and is associated with severe preeclampsia, renal failure, hypertensive encephalopathy, chemotherapy, and immunosuppressive medications. The MRI of the brain is the gold standard for diagnosing PRES, and the T2 weighted images typically reveal punctate or confluent symmetric, you can see here, bilateral hyperintensity in the parieto-occipital lobes, and CT demonstrates symmetric hypodensities that usually involve the occipitoparietal regions of the brain. Now, it's very, very typically seen in this particular picture, the picture of PRES. Now, the postulations why this occurs is vasogenic cerebral edema is one of the causes. It can be ischemia of the brain tissue. And why only in the posterior circulation? Because that is more susceptible, less sympathetic innervation of the vertebrovascular vasculature to protect the parenchyma from rapid increases in arterial blood pressure. And the management is by discontinuing the offending medications, lowering the elevated blood pressure, and treating any seizures if they are associated. Another conglomerate and component of HDP is the chronic hypertension. And this is definitely a disease which requires a lot of attention in the today's changing social issue where there is a lot of metabolic disorders, NCDs, and women are obese. Also, they choose to become pregnant a little later in life. And they have been chronic hypertensive maybe for a long period of time. Therefore, having these Charcot-Bouchard aneurysms in their brain, in especially the deep penetrating arteries such as basal ganglia, putamen, thalamus, adjacent deep white matter, pons, and the deep cerebellum. And these are usually weakenings predispose these small vessels to rupture with sudden hypertension, which can occur during pregnancy. However, there is a good news. Eclampsia may be considered a preventable disease in many of the cases, and I firmly believe in this particular dictum. Now, 100 years ago, in high-income countries, eclampsia occurred in about 70 per 10,000 pregnancies, and the maternal case fatality rate in women with eclampsia was about 20 to 40%. Today, again, eclampsia occurs in less than 1 in 10,000 pregnancies, and the case fatality rate among women with less than 1%. The progression of preeclampsia to eclampsia, this is something that we can monitor. The case fatality rates of eclampsia, both complications reduced by about 99%, and most of the reductions in the maternal mortality occurred between 1930 and 1970. And the game changer was magnesium sulfate, which improved the survival and not only is important for treating but preventing eclampsia. It is important that it should be continued for at least 24 hours from the time of the last seizure, and the patient should be monitored closely for toxicity. And even with the risk of side effects and toxicity, many studies have proven that magnesium sulfate is much more superior in the treatment of eclampsia compared to other drugs. And I want to ask for pardon for saying the word toxicity, because is India chapter believe that we should call it as magnesium sulfate overdose and not toxicity. So before magnesium sulfate, eclampsia was first associated with albuminuria in 1839, before hypertension in 1897. And these discoveries, coupled with introduction of antenatal care in the first decade of the 20th century, led to better understanding and earlier diagnosis of the precursor. Despite this, mortality from eclampsia remained high in the 20th century, necessitating active search for treatment. And this is my alma mater, the Vijay Medical College, where during my MBBS training, we were using the famous Lytic. And later on, there was promethazine, chlormethazine used alternatively, and the maternal mortality continued to be 2.2%. And then things changed from 1984 to 1989, when as an intern in St. Luke's Hospital nearby my place, I found that there were still the uses of Lytic cocktails, sometimes diazepam, and women used to continue fight this eclampsia. But what happened in the meantime? When used intravenously in epilepsy had better response and proposed to use intravenously in eclampsia women. And the use of magnesium sulfate for seizure prevention was first discovered in 1906 Later, its use was advocated and sometimes adopted in United States, but very rarely in Great Britain. And this hesitancy, because of that word toxicity, I always feel, but it gained prominence in UK. But since the arrival of diazepam and later phenytoin, there persistence or hesitancy in using magnesium sulfate. And this reluctance stemmed from the widespread use of these medications for other forms of seizures, their cost effectiveness and availability. And then superiority of magnesium sulfate was found in the fact that it was not only effective, but it was also found to be 60% of providers surveyed indicated that they would use magnesium as an anticonvulsant from eclampsia in 1998, up from only 2% of eclamptic women who received magnesium in 1992. And then came the famous MAGPIE trial, and the controversy largely ended.
Only 1 minute left,
sulfate.
ma'am. 1 minute left.
The risk of recurrent seizures in eclamptic women by 52% understood. So therefore, it was found that magnesium sulfate is much more effective, not only for seizure protection, but also for prevention of eclampsia. Now we have to understand that these inflammatory cytokines give rise to whatever. Should I not speak then? I will stop, Supriya. Supriya, I understood it is 1 minute. But if you want, I can stop.
Supriya, don't
stop.
say it. Okay. Yeah, Girija, please continue. It's a very important subject and no other speaker. She's the best speaker on this subject. We will like to listen to you.
No, it's okay. I can just stop. No problem. I can just stop. We can just share this presentation. There's no need for me to continue. I can put my slides in the, in the group.
Please go ahead, Girija.
Okay, fine. So now let's look at this particular algorithm of eclampsia, where at 0 minutes you have to give airway, lateral decubitus, suction, oxygenation, restrain with care, and then don't put them in a dark room, secure the IV line, put in a Foley's catheter, ensure that you are seeing their oxygen saturation, do a random for proteinuria, and attach a multipara monitor. At 10 to 15 minutes, samples for blood, antihypertensive treatment, magnesium sulfate infusion, and the pre-charge regimen has to be undertaken. And by 15 to 20 minutes, you should be able to important labs, do the fetal assessment and plan the delivery. Stabilize the patient. Once she is stable, consider delivery and do obstetric paradigm and consider transfer to HD or ICU facility. If there are recurrent seizures, repeat the 2 gram bolus after the primary 4 gram dose, and refractory seizures can be considered treating with lorazepam or consider intubation if it's necessary. I will skip this slide, but one can give magnesium sulfate by infusion pump, but since we will not have the time, we will not go into the details. You have to remember the mechanism of actions of magnesium sulfate and give the right dose of magnesium sulfate. It's very important that you are aware of the pre-charge regimen as well as the Zuspan regimen, and be ready with the magnesium sulfate box. And there is something more which has come now in our arena of prescriptions. We now have a ready-made formula 4 gram magnesium sulfate, which can be delivered in 100 ml over a period of 5 to 10 minutes. And that can be a savior. You don't have to calculate, find how many ampoules to be given and all that, and ensure that your patient is properly monitored. And if she is having any kind of a refractory problem, then you can consider stepping up your care and then calling in specialists such as critical care specialist or maternal fetal medicine specialist. Ensure that you are using the magnesium sulfate checklist appropriately, where you can see that the magnesium sulfate dose is given, antihypertensive medicines is given, and then you have to ensure that the patients are safely taken care of. Thank you so much for the patient hearing.
Thank you, ma'am. Thank you for the wonderful presentation and the great orator you are. Everybody must have really benefited from your talk. Thank you so much. So moving ahead,
Girija, there are lots of requests from the audience and the delegates for your presentation. So they will be very happy if they have not listened to you. But yes, they can definitely follow whatever guidelines and the subject in depth what you have spoken about. Excellent presentation, Dr. Girija.
Thank you so much. I would have been happier if I was not interrupted. I would have finished it well in time.
yes,
Really, thank you. No problem.
Thank you, ma'am. So over to Dr. Murlidhar Pai, sir. He will be talking on management of complications of HDP other than eclampsia. So he is the Dean of Sikkim Manipal Institute of Medical Sciences and Professor of Obs and Gynae in this place. So sir, over to you and you can share your presentation.
Thank you very much. Okay. Dr. Girija and Dr. Suchitra madam have made my presentation easier. So I'm not going to repeat whatever they said. I will be concentrating only on the management of other complications other than severe preeclampsia and the eclampsia part of it. So what are these other complications? Again, both of them have given a glimpse of it. I'm just going to repeat it. It may be something like a reinforcement. Number one is abruption with or without DIC. Then the HELP syndrome, pulmonary edema, which is a part of severe preeclampsia, and intrauterine fetal demise, persistent severe postpartum hypertension, which can lead to preeclampsia, the eclampsia after 48 hours, and then finally, of course, stress, which Dr. Girija was enumerating. So let us look at the management in general, whether you have any of the complications which I mentioned in the previous slide or not. In general, the management of preeclampsia, whether it is mild or severe, includes control of hypertension by using antihypertensives, which Dr. Suchitra has beautifully elaborated, the drugs and everything. So that goes without saying. That has to be continued. The second one, of course, the prevention of eclampsia or treatment of eclampsia by using anticonvulsives, which Dr. Girija has beautifully explained. That also should continue. And then, of course, the early delivery, irrespective of gestational age, which is very, very important because we all know the preeclampsia or eclampsia is due to the placenta sitting there. And that is the one which is causing all sorts of problems, including immunological problems. Till today, we have not clearly understood, as Girija said, earlier we thought it may be edema and the hemorrhage, but there are so many things that can be produced by the placenta, which is causing the problem. So unless the placenta is out, the problem may not be solved clearly. And then finally, the my domain, which I'm going to explain, additional treatment for each complication, whatever may be the complication in picture, in HDU, the OBGs nowadays have got HDUs with them, or multidisciplinary ICU with the help of multidisciplinary team. So I'm going to elaborate one by one. Let us say the patient of preeclampsia lands up in abruption. This is one of the commonest causes of abruption. There are so many others. But here, what we have to do in addition to continuation of antihypertensives and starting probably the anticonvulsives, because this is considered as one of the imminent symptoms of preeclampsia or eclampsia rather. If the abruption occurs without DIC, that means the initial stages, she has not gone unnoticed, she has not landed up in DIC, then of course, we have to consider whether she is already in labor. Usually, whenever abruption occurs, they go into labor spontaneously. And if there is no fetal distress, some obstetricians, they're augmenting the labor with ARM and oxytocin and try to deliver. But some others may say, I don't want to take any risk with the fetus. I want to go for emergency cesarean section, because even if the patient is in labor, it may take few hours before she delivers, unless she is in the active phase. Now, the new active phase is more than 5 centimeters. Then, of course, there is a case for doing ARM, which also helps abruption to release the intrauterine pressure, and we can also know the staining of the liquor. And then there is a small case for vaginal delivery with the help of instruments. Well, I have put steroids and magnesium sulfate as question mark because sometimes we may not get adequate time for the steroids to act. Ideally, once you give the 2 doses of steroid, we have to wait for 24 hours. And same way for magnesium sulfate here, It is not only for the prevention of eclampsia, it is also neuroprophylaxis of the fetus. Again, we need a minimum of 24 hours window. All the time, we may not be able to get this window. However, our neonatologist in Manipal used to say, for whatever worth it is, you give a dose of steroids. But the priority is to deliver rather than wait for steroids to act on the baby. Baby will be looked after by the neonatologist. Suppose she is not in labor, and if there is no fetal distress, again, a small part of obstetricians venture into induction of labor with ARM and oxytocin, and they want to still deliver. The only argument they give is there is no fetal distress. But I wonder whether that is prudent, because whenever the baby is alive, that's what most of my teachers have told me in Manipal, that if the baby is alive and in abruption, it makes sense to just give the live baby rather than venturing into labor, because labor is always, the length of the labor is always unpredictable. And then, of course, mother's life is also at risk here in a case of preeclampsia. She may throw a fit. So it is better to deliver immediately. Of course, nobody will argue if there is fetal distress and emergency cesarean section is the only way to go ahead. And again, I'm reiterating, it goes along with saying continue with the antihypertensives, continue with the magnesium sulfate for prevention of eclampsia or treatment of eclampsia. Now, be prepared for component therapy in case she immediately slips into DIC. Now, the next scenario is she is having abruption with DIC, but no renal failure yet. Whenever there is DIC, it is no brainer. We have to start component therapy immediately. If you have a transfusion specialist in the college or the hospital, it's excellent. We can initiate the MTP, that is massive transfusion protocol, and they will give us whatever we want, whether it is platelets or the plasma or whatever we want, cryoprecipitates. If the fetus is alive, here it makes sense to deliver immediately by emergency cesarean section. You have additional protection of anesthetist being around, and it is in the controlled environment. The patient is, can be immediately intubated in case she goes into other types of adult respiratory distress. If the fetus is dead, then is the dilemma whether to go for section or whether to go for vaginal delivery. There is a case for induction of labor with ARM and oxytocin and delivering the fetus. If there is additional renal failure, there is no question after the delivery, we must shift the patient to either a nephrology setup or an ICU where dialysis is possible. The next complication is HELP syndrome. Of course, HELP syndrome is an indication to deliver immediately. I don't want to repeat that. But what is the treatment per se for HELP syndrome? It is platelet transfusion. Either you can go for single donor platelet, which is supposed to be superior, or you can go for pooled platelet transfusion. This is a temporary measure, so this is not going to actually help in the long term. But steroids, which we give usually for lung maturity, here it also helps in building up the platelets, the 2 doses that we give. Delivery, of course, protocol is as per the HDB protocol. I'm not going to waste my time on that. Rule out fulminant hepatic failure, because in hemolysis, there can be jaundice, severe jaundice, and you may get confused with other causes of jaundice, even low platelets, elevated liver enzymes. Of course, all of us know the elevated liver enzymes are very, very high in case of hepatitis A, and in fulminant hepatic failure, there is, of course, low glucose levels, and whatever it is, the treatment is immediate delivery and taking care of the rest of the problems. Pulmonary edema can occur even in the antenatal period, not only in the postnatal period. Here is the case where diuretics are indicated. Otherwise, all of us know we avoid diuretics in the antenatal period. We usually restrict their use for the postnatal period. Ventilatory support is mandatory because the patient will be having respiratory distress. I want to caution the delivery, of course, protocol is imminent delivery. I want to caution that don't be under the impression that it is pulmonary edema of preeclampsia only. Sometimes you may be having a complex picture. The patient may be having other causes for respiratory distress, especially during COVID time. We always had complicated cases with COVID distress, respiratory distress, as well as sometimes H1N1 also could be a cause that has to be taken care of. Delivery is definitely indicated in all these cases, unless the patient's condition is very critical, where your physician and other critical care person says, let us stabilize the patient first with a respiratory problem, and then we want to deliver. That's the only small negotiable point there. Otherwise, always delivery is given priority in these cases. Diuretics will help in reducing the edema. IUFD, of course, it is like in any other case. IUFD, you have to conduct delivery, urgent delivery, especially in a case of preeclampsia. Most of the time, it may be due to abruption itself. Whereas in other situations of IUD, we may wait for up to 2 weeks. But here we don't wait, because that is also one of the signs of severe preeclampsia and maybe abruption. You have to rule out other complications that has led to the IUFD and treat them. Additional treatment depending upon the cause. As I said, abruption is the usual cause. We have to go back to the abruption protocol in this particular case. Persistent postpartum hypertension, of course, Dr. Suchitra ma'am has talked about it, but the main cause for persistence is the persistence of edema. That's why postnatally, we don't hesitate to give diuretics. It can be furosemide or any other diuretics that you are used to. I'm not going to give the dosage and other things here. And of course, you have to rule out other causes of renal and adrenal causes for the persistence of hypertension. She may be going in for a case of chronic hypertension. We have to rule out all the conditions that can give rise to hypertension. Renal investigations, adrenal investigations. We have to do sometimes a Doppler of the uterine arteries and other arteries are indicated in this. And we should not hesitate to take the help of the physicians to treat the hypertension part. Consider now ACE inhibitors in ARBs, which were banned during antenatal period. These are the favorites of the physicians. These can be utilized freely after the delivery. Monitor closely on long-term basis, because these patients are the ones who will develop chronic hypertension later in life. Now, PRESS, thanks to Dr. Girija, she has elaborated that, so I can run through these slides. Severe headache in the early puerperium is one of the early signs of to suspect PRESS. Patient will have continuous hypertension and she will have seizures after 48 hours. You suspect PRESS. Within 24 hours, of course, it is a part of the postpartum preeclampsia. But if it occurs anytime later, maybe day 5, day 6, day 7, you have to consider PRESS. MRI picture, madam has beautifully shown. I'm not going to elaborate on that. And then, of course, you also have EEG, which shows left hollow hemispheric epileptiform activity. So the treatment has to be with the help of neurologist and in ICU, preferably. Whatever may be the cause, whether it is PRESS or otherwise, the treatment of eclampsia or the treatment of seizures in PRESS is same. That is magnesium sulfate loading dose of 4 grams, 20 minutes, followed by 1 gram per hour infusion. Neurologist would like to add phenytoin drip or levetiracetam drip, and then they will continue it 500 milligrams per day for a long time. And then, of course, you can even consider dexamethasone to reduce the brain edema. There will be a lot of brain edema. And then mannitol some people use, and diuretic agents also are helpful in these conditions. So generally, postnatally, once the patient delivers, don't think that the problem is over. You should be monitoring these patients very closely. Even after 6 weeks, you should check their blood pressure. And then if there are features of severe preeclampsia is present, consider continuation of antihypertensives for longer time, change over to ACE inhibitors and ARBs. As I said, sometimes you may have to continue magnesium sulfate for 24 to 48 hours, consider diuretics, and all these patients should have a yearly checkup with BP, lipids, fasting blood sugar, BMI, because these are the candidates who can have repeat preeclampsia in the subsequent pregnancy, or later in life, they can have chronic hypertension. Thank you very much for the opportunity given. I have just broadly dealt all these complications.
Thank you very much, sir. You have very clearly shown to all of us what are the guidelines we should follow, and it's very much informative. Thank you so much. Now we are over with this session. So we come to the second session now. So second session of this talk is the gestational diabetes mellitus. And we have three brilliant speakers, Dr. P.K. Shah sir, Dr. Preeti Kumar, and Dr. Hema Diwakar. So we start with the first speaker is our most respected Dr. P.K. Shah sir. He will be talking on screening of hypoglycemia in pregnancy. So the sir is also just past president FOGSI, past chairperson of Imaging Science Committee FOGSI. He had been previously and member of Safe Motherhood Committee FIGO and member of many other committees. Sir, over to you for your presentation. Sir, you can share your screen. Over to you, sir. Is sir here?
Sir, but then, sir, please unmute yourself.
Sir, kindly unmute yourself.
Okay, okay.
Oh, he is not being able to.
Nilima, can you please unmute, sir?
Yes, yes. Mitali, please. The co-host.
Please unmute and please allow him to screen share.
Yes, ma'am.
Yeah. Thank you.
Now can I share the screen?
Yes, yes, sir. Yes, sir.
Thank you. Again, it has come host disabled participant screen sharing.
Yeah, Mitali, make the co-host. Yes, sir, you can share now.
I think Mitali, you make everybody, all the faculties co-host.
Yes, ma'am.
Can you see the screen?
Yes, yes, sir.
Yes, sir.
Okay. Shall I go ahead?
Yes.
First of all, thank you very much, FOGSI, Dr. Rishikesh, Dr. Madhuri, ICOG, Dr. Lakshmi, Dr. Parag, Dr. Ashok Kumar, and convener Dr. Sneha for giving me this opportunity to talk to you on screening for GDM. We all know that India is the capital of diabetes mellitus. And we as obstetricians come across many patients who have got diabetes nowadays. There are so many screening methods that you learned so far that we get confused at the end of it, learning it. So I hope today at the end of my talk, you'll understand what we should do in our practice and what we should keep in mind. And that's it. So what is GDM? It's a carbohydrate intolerance with recognition or onset during pregnancy, irrespective of treatment with diet or insulin, and whether or not the condition persisted before or after pregnancy. Screening. Now, whom to screen, when to screen, which test to perform, and how to interpret. Now, whom to screen. Basically, it is the high-risk pregnancies that we used to screen once upon a time, depending on the history, family, etc., etc. But now it has been suggested that all the women should be screened, and what we call now as a universal screening. Now, whether it is beneficial or not, we'll talk, and whether it is cost-effective or not, also we'll talk. If you do only traditional screening in conditions that are mentioned here, like more than 25 years of age, ethnicity, Hispanics, Native Americans, South or East Asians, Pacific Islands, African American, BMI more than 25, previous history of glucose tolerance, past history of gestational diabetes mellitus, and history of diabetes in first degree relatives, what will happen? We will miss many patients. National Diabetes Data Group advocates universal screening, especially in South Asian ethnic group. Screening is essential in all pregnant women, as Indian women have 11-fold increased risk of developing glucose intolerance during pregnancy compared to Caucasian women. As I was telling you, if you do only traditional screening, 45% of pregnant women will go unscreened, and 35 to 50% of GDMs would be missed. Compared with risk factor-based screening, universal screening for GDM is better anytime because it detects more cases and improves maternal and fetal prognosis. The International Diabetic Federation, I thought only we have federation, FOGSI. There is the International Diabetic Federation. There is a paradigm shift in approach as per their guidelines. Assume that the woman has diabetes unless proven otherwise. Remember these words. And testing is done to reassure the patient that she doesn't have GDM. This is something which is new and we must follow this. How much ado about nothing. Why is it important to screen? We all know all complications because of gestational diabetes. The first column is normal. This is gestational diabetes. This is diabetic mellitus. You can see birth weight, macrosomia, C-section, hypoglycemia, hypocalcemia, hyperbilirubemia, polycythemia, cord CPAP, and cord glucose. If you compare this with GDM, you see the number of times it increases in GDM. And that is the reason we should do screening. Also, the number of congenital anomalies compared to normal and in diabetes mellitus, the increase in CNS, congenital heart disease, respiratory disease, intestinal hyperplasia, anal atresia, renal and urinary defects, upper limb deficiencies, lower limb deficiencies, upper lower spine and caudal dysgenesis. They're all increased many folds. That is the reason we don't want a woman to have hyperglycemia during pregnancy, if possible. And if it is there, we should detect it early and treat. We also know the maternal morbidity it causes if she has hyperglycemia during pregnancy, like polyhydramnios, preeclampsia, eclampsia, abruption, preterm labor, C-section, increased number, and postpartum uterine ectosis. All those who are listening to me, if they want to know in detail benefits of screening, there is a Cochrane library on screening and subsequent management of gestational diabetes for improving maternal and infant health. You can refer to this. So there is a Cochrane meta-analysis that included 4 trials with 3,900 plus women. What it showed, there is a strong evidence that treating GDM is beneficial and improves outcome, and research is required for identifying ideal screening practices. So what is the ideal time for screening? First is the first trimester. If she doesn't come at that time, whenever she comes for the first time for booking, antenatal visit, and then 24 to 28 weeks and 32 weeks. What are the benefits of early screening? You can pick up pre-existing diabetes. If the HbA1c is more than 6, you know that she was having diabetes before she got pregnant, especially in patients with high risk factors. Why? Because Indian women have 11-fold increased risk of developing glucose intolerance during pregnancy compared to Caucasian women. What is the role of repeat screening? A significant number of women whose glucose tolerance, that means 2-hour value of less than 140 milligram deciliter, was considered normal in first visit, they develop glucose intolerance in subsequent visits, and that is the importance of repeat screening. Why? 28% of these patients who had normal 2-hour blood glucose have GDM at repeat screening. This is by Professor Seshaya. What is the ideal time? As I told you, after early screening, you can repeat it at 24 to 28 weeks. Which test to perform now? Very important. Whether you do routine blood sugar fasting blood sugar, or not routine random, fasting PLBS, 50 gram glucose challenge test, or 75 gram or 100 gram OGTT. Whether urine sugar as a screening test is acceptable? The answer is no. Sorry, because it is unreliable, and usually we do it in hospital on OPD settings. 73% of urine sugar positive may not have GDM. A large majority of GDM may not have glycosodium. What about random and fasting samples? If random is more than 200 milligram per deciliter and fasting at 28 weeks more than 126 milligram per deciliter, it has a lack of conclusive data. And you can't rely only on these findings. Reproducibility and sensitivity issues are there, and some patients only have high levels post meals. So you can't rely on these. What about fasting blood sugar and post lunch blood sugar? They are more sensitive when combined, but it is cumbersome, as you all know. PLBS is more reliable, and it is not as sensitive as 50 gram glucose challenge test. So what is 50 gram GCT? This most preferred test world over, recommended by Royal College and American Association of Diabetes. Cutoff value of 130 milligram per deciliter will give you sensitivity of almost 80% and specificity of 87%. What is the ideal cutoff value? When you have 50 gram oral glucose, irrespective of fasting, American Diabetic Association guidelines tell you that cutoff after 1 hour is 140 milligram per deciliter. It identifies 80% of human with GDM, and the cutoff of, if you take it as 130, it identifies 90% of GDM. I hope I have confused you by now by telling you different methods of testing. Nice guidelines, Royal College of Obstetrics and Gynaecology, American Diabetic Association, World Health Organization. What are we supposed to do? We have now 75 gram OGTT by WHO. They don't favor fasting. They say if you give 75 gram oral glucose and do after 2 hours, if it is more than 140, it is GDM. According to NICE guidelines, if one of these values is positive, then she is GDM. Fasting more than 126 or 2 hours more than 140, same as WHO. ADA, fasting more than 95, 1 hour more than 180, 2 hours more than 155. Okay. What about single step, single visit value? WHO recommendation of 2 rpg more than 140 milligram per deciliter with 75 gram oral glucose administered without regard to the time of the last meal. Non-fasting women correctly identify subjects with GDM. There is no need of further testing. Diabetes in pregnancy study group in India, that is DIPSI. Diabetes in pregnancy study group in India. Pregnant women need not be fasting. It causes least disturbance in a pregnant woman's routine activities. And it shows that both screening and diagnostic procedure, when you do it as a universal test, if possible. Now there was a DIPSI guideline RCT. It concluded that this study proves advantages of adhering to DIPSI guidelines in the diagnosis and management of GDM for a significantly positive effect on pregnancy outcome. How do you improve the outcomes? The treatment of GDM women with 2 rpg more than 140 milligram per deciliter was associated with a reduced risk of adverse pregnancy outcome. And DIPSI criteria is a one-step, cost-effective, and evidence-based procedure to diagnose gestational diabetes mellitus. Diagnosis of gestational diabetes mellitus in Asian Indian women is very, very, very important. And this particular test is very good for country like ours. What is the evidence for DIPSI criteria? The diagnosis of GDM with 2-hour post-glucose 140, more than 140 milligram per deciliter, and treatment in a combined diabetes antenatal clinic is worthwhile. With a decreased macrosomia rate and fewer emergency C-sections. So again, this is a very good paper. Now, you must be confused with what you should follow. Whether the fasting should be more than 126, whether 1 hour more than 180, 2 hours more than 156. Like that, there are so many things that have been taught to us. But now you remember one thing very clearly, the DIPSI criteria classification. During pregnancy, if you have following 75 grams oral glucose, 200 milligram, more than 200 milligram per deciliter, she is a diabetic patient, diabetes mellitus. If the 2-hour post-glucose is more than 140 but less than 200, that means up to 199, it's gestational diabetes mellitus. If the 2-hour glucose is more than 120 but less than 140, it is gestational glucose tolerance, intolerance. Mind you, you do not use impaired glucose tolerance during pregnancy. It can be used only if she is not pregnant. Please remember this very clearly. What are the take-home messages, ladies and gentlemen? Ethnic predisposition, very important. We all know that in our country, we need a test that can pick up a patient whether she is gestational diabetic or not. We need universal screening. We have today a simple thing like DIPSI, single step, single value, same thing as WHO, 75 gram glucose load, 2 rpg more than 140 grams per deciliter. Remember only this much. There is no need to unnecessarily get confused when it comes to screening. Thank you very much for patient hearing, and I hope I have finished it on time.
Thank you so much, sir. Thank you for enlightening us on such an important topic. And you're well in time, sir. Thank you. Thank you so much, sir. So now we move on to the next topic that will be taken up by Dr. Preeti Kumar. That is hypoglycemic agents in GDM. Madam is Chairperson Safe Motherhood Committee FOGSI and Vice President Lucknow OBGY Society. She is a proud organizing secretary of so many of conferences, AICOG and many more. So over to you, Dr. Preeti ma'am, for your presentation.
Thank you, Supriya. Are my slides visible?
Yes.
And I'm audible. Thank you so much. So before I start my presentation, let me thank Dr. Lakshmi Shikhande, Dr. Ashok Kumar sir, Dr. Parag and Dr. Sneha for inviting me here to deliver my talk on intricacies in the use of hypoglycemic agents in the GDM. We have just now heard Dr. P.K. Shah sir talking about the single step test, and I think everyone in our country should follow the DIPSI criteria. And my presentation is also based on Government of India guidelines revised in February 2018 for diagnosis and management of gestational diabetes mellitus. It is very important to understand that GDM, like type 2 diabetes, is a heterogeneous disorder with variability in hepatic adipose tissue and skeletal muscle insulin resistance, as well as beta cell dysfunction, resulting in wide distribution of glycemic patterns that are not at all effectively targeted by same agent. Again, it is very important for us to understand whether it is a diabetic environment or the genetic predisposition that causes type 2 diabetes in the offspring. It has been seen that the exposure to the diabetic environment in utero is associated with increased occurrence of impaired glucose tolerance and a defective insulin secreting response to adult offsprings, which is independent of the genetic predisposition of type 2 diabetes. So carry home message from this is it all starts in utero. Hyperglycemia in pregnancy is very, very important, and we need to diagnose it early and manage it. Again, we need to understand that the physiology and pharmacokinetics differ in pregnant women as compared to non-pregnant women. The complications Dr. P.K. Shah has already highlighted, but again, we need to understand that hyperglycemia in pregnancy is also associated with long-term complications in mother and also in the baby. I have made this slide because you cannot just take these components separately, manage them separately. We need to balance the glycemic as well as obstetric complications. Sometimes in your practice, I'm sure most of you must have found that the glycemic controls are very good, but still there are obstetrical complications. Sometimes your postprandial values are very well controlled, still you find hydramnios, still you find large size baby. So it is very important for us to manage the obstetrical as well as glycemic management together. Now, when we talk about the hyperglycemia in pregnancy, we can have two different entities. One is diabetes in pregnancy, that it is pre-GDM. The mother was already diabetic and she lands up in pregnancy. And the second part is that she may be a gestational diabetes, which develops in the mainly in the second half of the pregnancy. In both the cases, the pregnant mother may need oral hypoglycemics or insulin for the or any other agent for the management of hyperglycemia. But the fact is 50% of all pregnancies with and without diabetes are unplanned in our country, which leads to high risk of poor pregnancy outcomes among women with diabetes. These are the three important prongs, I might say 4 prongs. One is diet, exercise, insulin, and oral hypoglycemics. We need to understand that medical nutrition therapy plays a very, very important role. And as per the Government of India guidelines, whenever you find a high sugar that is more than 140, you should give MNT and exercise and repeat the sugar levels after 10 days. This is what is mentioned in the Government of India guidelines. You need not to do a fasting level. Just go ahead with the postprandial after 2 hours and check for the sugar levels. If they are more than 140, then you need to add insulin or the oral hypoglycemic agents. This is a very important article, which is by Dr. Shishaya. I want to read it out and please listen it carefully. After 20 weeks of gestation, the fetus begins to swallow the amniotic fluid. In addition to the placental transfer of glucose, ingested high glucose amniotic fluid also stimulates the insulin secretion. So if the fetus is exposed to the high sugars, the insulin secretion will increase, and postprandial hyperglycemia of even less than 1 hour once a day in mother may produce fetal insulin stimulus throughout the oral route for more than maybe 5 to 6 hours. So even if there is a small peak of hyperglycemia in the mother, the baby can have a insulin stimulus for a longer period of time. Hyperinsulinic macrosomic fetus apparently helps to attenuate and normalize the maternal glucose despite poor metabolic maternal control. And that is why this is the reason why sometimes you see normal blood glucose level, but still the metabolic control is poor because the baby is trying to, normalize the mother's sugar. And it provides an explanation for why some mothers with fetuses with all the characteristics of diabetic fetopathy have apparently good glucose control. And this is known as fetal glucose steal syndrome. Again, I think Dr. P.K. Shah sir has rightly highlighted that when should you call a patient a diabetic? Very simple test. If you do a random, most of them of the OBGYNs are doing a random. I'll share some of the data with you. If you find any value more than 200, it is a frank diabetic. If the values are between 140 to 190, as mentioned by Dr. P.K. Shah sir, it is GDM. You should not miss 120 to 139. This value is also very, very important if you find it in the first trimester. Please do not ignore these patients. You should tell them the MNTN exercises because these are very, very prone to develop GDM later on in the second half of the pregnancy. Again, if the values are less than 120, they should be considered as normal. This is the Government of India guideline. A pregnant woman with GDM, give her MNT, medical nutrition therapy and physical exercise. Do her after 2 weeks, do her sugars after 2 hours. And if you find the postprandial blood sugars more than 120, start oral anti-diabetics or metformin or insulin, whatever is feasible. Then monitor fasting blood sugar and 2-hour postprandial blood sugar every third day or more frequently on insulin, and bi-weekly for metformin dose adjustment to maintain normal blood sugar levels. As per the high-risk pregnancy protocol, or you can recommend refer her to the physician. But if the values are less than 120, you need to continue MNT and physical exercise. Now, there is a very important quote by Josper. Laughter is the best medicine unless you are diabetic, then insulin comes pretty high up. But then there is a fear of injections. And most of the time, the mother-in-laws and the patients are very worried about how to take the injections. Now, if you talk about the insulins, because I will talk only about the 2 drugs which are very commonly used in pregnancy because the time is less. Insulin in GDM is a proven treatment and is the best treatment for the hyperglycemia in pregnancy. It does not cross the placenta, best outcome for the mother and baby, and it is a wonder molecule. Again, insulin should be considered as a first-line treatment. I would repeat again, as a first-line treatment if you have a very high sugars in the first trimester. Any value crossing more than maybe 180 or 190 or maybe 200, please do not start oral anti-diabetic because these are not going to affect much. And first trimester oral hyperglycemic agents are still controversial in our country. So if you diagnose early in less than 20 weeks, insulin is the drug of choice. But if you want to prescribe, you can give oral hypoglycemic agent as well. If you find a hyperglycemia at the advanced gestational age, like more than 30 weeks, do not start oral, try to put her on insulin. If you find a fasting value more than something 110 or 125, put her on insulin because oral hypoglycemic agents will not work. If you find any obstetrical complication in that patient like hydramnios or macrosomia, put her on insulin, even if the sugar levels are controlled with your oral hypoglycemic agents. So concerns about insulin, we all know insulin requires labor-intensive monitoring and teaching. Injection of insulin at multiple times is again cumbersome. Then food may not be eaten on time. Hypoglycemia again is very important. We need to teach them about hypoglycemia, concerns about weight gain, and again the administration cost and social implication. Insulin requirement increases with pregnancy. And these are the doses, 0.7 units per kg in first trimester. It may increase to 1 unit per kg from 36 weeks till delivery. Again, these are the insulins. Government of India approves only NPH, but these are the insulins which are approved in pregnancy. There are studies which are coming up for glargine as well. Regular NPH, Lispro, Aspart, and Detrimal. These are the insulins which are approved by various organizations to be used in GDM, but there are no standardization for monitoring protocols in GDM. Again, I wish to highlight here, please do not use HbA1c for monitoring in pregnancy. It has its own value in the pregnancy. In the first trimester, if you find high sugar levels, do HbA1c and find out whether the patient was pre-GDM or not. The target should be maintained fasting below 90 and postprandial less than 20. Few again practical tips that I want to give you, that can you give insulin in the abdomen in pregnancy? The answer is yes. You can give the insulin in abdomen. The fastest absorption of insulin is in abdomen, followed by upper arm, then the thigh, and then the buttock. You should be aware that it should be a rotational kind of a injection. You should not give it one particular side because sometimes there is a lipohypertrophy that reduces the insulin absorption. Again, point of caution is if you find a drop in the insulin requirement in the pregnancy, be careful, the fetus can be at risk. This is a very crowded slide, but I have taken it from the Government of India guidelines, how you start the insulin in a pregnant woman. Again, want to address here that you should also be aware about what is the peak time of insulin, because the various insulins which are available, they have different onset of action and they have different peak time. So you should be very aware because some insulins are clear, some are cloudy. So NPH and mixed insulins are usually cloudy. Human insulin plain is always clear. So asparts and the analogs should be used for short postprandial hyperglycemia, you can just give a bolus just before the lunch and rest of the sugars can be maintained. But if you need a longer duration of action, then long-acting insulins are the drug of choice. So you need to have a opinion with the endocrinologist or diabetologist. But as an OBGYN, you should also be aware about the different types of insulin, mode of action, onset of action, and which insulin should be given, how, what should be the time before giving the insulin. Like if you want to give a long short acting, you have to give just with the meal. But if you want to give a longer acting, then it has to be given at least in half an hour before the lunch. So oral anti-diabetic agents, again, these are effective. And there are certain concerns about the oral agents. But metformin is the most commonly used drug. It suppresses hepatic glucose production and it decreases the insulin resistance. It crosses the placenta and milk. It is seen in the milk concentration, but it is less than 10%. No teratogenicity is noted, and neonatal outcome is almost similar to insulin. There are certain concerns with the metformin. Metformin used in the first trimester, Government of India does not endorse still. Intolerance in metformin, again, you have to shift this patient to insulin. Insulin used from 12 to 20 weeks, again, Government of India has clearly mentioned that you should use it beyond 20 weeks. You should not use metformin when there is a placental insufficiency like hypertensive disorders or cholestasis or IUGR. Now, this is a paper which has been recently published, and this also shows that metformin results in relative nutrient restriction that could adversely affect the function, growth, and differentiation of fetal and placental tissues. So that is why I said it should not be used in hypertensive disorders. Insulin would be a drug of choice, like in preeclampsia or IUGR cases. Now, this is the same paper said when you compared with the insulin, the results were almost similar. When you see the fasting of the postprandial, HbA1c was similar, less gestational weight gain, less gestational hypertension, and the results of metformin and insulin were almost similar. So this is another paper, and this talks about the short-term complication when you use metformin versus insulin. It has been seen, this paper was published in October 22. Metformin is safe oral anti-hyperglycemic drug without an increased risk of short-term neonatal adverse outcome. So it can be safely given in pregnancy. Now, this is the paper which talks about the adverse outcome for long-term study. I think most of you must have heard about the MIG-TOFU trial, where metformin was compared with insulin, and long-term effect were seen that the subcutaneous fat was more in these fetuses which were put on metformin. This is the largest study till date. 2022, it was published. From the data from 2004 to 2016 have been collected, and metformin 3,967 group and insulin 5,733. This shows that the maternal exposure to metformin and combination of treatment with metformin and insulin was not associated with any of the long-term complication. So this is the recent update as far as the metformin is concerned. What guidelines say? Metformin can be used beyond 20 weeks. This is the Government of India guidelines. That is why I said early gestation, you should be very careful. Try to, you can give metformin, then again, the insulin is a drug of choice. There are various organizations which have mentioned that the data shows that the insulin and metformin can be safely used in pregnancy. But of lately, recently, UK national guidelines have recommended use of metformin in all the trimester. This is a recent update that metformin can be given in all the trimester, and UK has endorsed it. So in our country like ours, oral anti-diabetic agents are doable option, but again, insulin is the best drug. So these are again dilemmas: use of OHA in first trimester, 12 to 20 weeks, HbA1c monitoring in pregnancy for sugars, no. Insulin and oral hypoglycemics, again, you can combine both insulin and oral hypoglycemic agents. Sudden drop of sugars, you should be very careful about the well-being of the fetus. Use of oral hypoglycemics in preeclampsia or IUGR, you have to be very careful. When you're putting a patient on steroid, definitely you need a higher doses of insulin. You need to admit 4 or 5 days for 4 or 5 days, escalate the dose of insulin, but you can safely give steroids in these patients. This is the chart how you maintain in the intrapartum period, and then immediately postpartum, you have to check the blood sugars. Usually, if the patient is on MNT, it returns back to normal. For oral hypoglycemics, again, you have to repeat after 72 hours, and same is for insulin, and then you taper down the dose. Regarding the follow-up, 6 weeks, 6 months, and then yearly thereafter. And here you have to do a 75 OGTT fasting and postprandial, not like a during the pregnancy, you give non-fasting or fasting. Here it should be fasting 75 gram glucose, and fasting should be less than 140 and postprandial less than 140. 100 fasting and less than 140 is the postprandial. Now just share few slides. We are starting FOGSI Vistrit in Karnataka. This is on GDM and anemia. Just sharing some of the slides here because we did the pre-training survey just to give you the idea how the things are moving in our country. We launched it on this month only, 14th of June. And few questions that we had put in: after how many days the MNT you should retest? The answer is 15 days. And as you can see, there is varied answers. 7 days, some people have written 7 days, some have written after 1 month, some have written after 3 weeks. So again, which test are you doing after MNT? The correct answer is postprandial. We should not do fast. If you're doing fasting, the patient is comfortable, you can do it. But as per the Government of India guidelines, it is only postprandial, and 11% they did the correct answer. At what level should the fasting and 2-hour postprandial should be maintained? This was another question for the doctors, and 33% responded that the fasting should be 100 and the postprandial should be 120. Only 38% responded to the correct answer of less than 90 and 120. Now, if the mother is detected for GDM at 10 weeks, do you prescribe metformin? Most of us are prescribing metformin in the first trimester, though the Government of India guidelines say that you should start after 20 weeks. So do you monitor GDM? Again, varied opinion with the HbA1c. Many of us are following HbA1c for the sugar control. The answer is you should not use HbA1c for the follow-up during pregnancy. It has a specific role, and you should follow only by the sugar levels. Now, postpartum follow-up, again, a big gap, as you can see. Some have written 1 week, some have written 6 weeks, some have written 12 months, and 44% have responded to the correct answer. So the next step I would say is not about the diagnosis. It would be the primordial prevention of gestational diabetes. This is now the mission of the Diabetes Forum and Dr. Shishaya, that now is the step that we should prevent the occurrence of gestational diabetes in our country. So this is all about my presentation. And if there are any questions, I would be happy to answer. And I'm really thankful to Dr. Hema Divakar because we are doing this FOGSI Research project under her guidance. Thank you, Dr. Hema.
Thank you, Dr. Preeti Kumar, madam. It was a wonderful presentation and very crisp and brief, very informative. Thank you so much. Now, moving ahead, we come to the next speaker, who is none other than Dr. Hema Divakar, madam, who is going to talk on obstetric management of HIP. And then madam is Medical Director, Divakar Hospital, and coach, CEO and Chairperson, Asian Research and Training Center of Skill Transfer. Madam was the past president of FOGSI. Madam has been awarded by many awards like PIGO Women Achievers Award, Global Asian of the Year Award, FICC Award for Excellence and CME Excellence, and CSR Impact Award for Divakar Trainings. So, madam, lots and lots of, I cannot read complete CV. I know madam is a wonderful human being also. Madam, over to you for your wonderful presentation. Everybody is waiting to hear.
Thank you, Supriya, and thank you, Sneha, for putting us all together through the mega platform of ICOG. I see that the certification course has attracted many delegates, and this is indeed the need of the hour, because the last couple of slides which Dr. Preeti showed clearly brings out that there is a lot more work for us to do, for sure. So there have to be platforms like where we can go from here. All the way through Dr. P.K. Shah's lecture, Dr. Preeti's talk, and then now to me, the obstetric management of GDM. We primarily are obstetricians, and we always thought that if we look after the mom and baby in the obstetric vertical, we are done. But now the hypertensive disorders, then hyperglycemic disorders, everything is presenting as a tsunami of comorbidities within our ambit. And we are forced to know more and to do our best for the mother and child unit. So the principles of obstetric management, if you want a good outcome, should ideally start right in the pre-pregnancy stage. And then if the mother is hyperglycemic, make her normoglycemic somehow, do whatever it takes. And then you will not have the baby exposed to a high sugar environment, which means that it has to behave similar to the normal pregnancies. Both short-term and long-term problems, because we as obstetricians should not think take-home mother, take-home baby is the end of the story, because the story then actually begins in both their lifetimes. This child will become childhood obesity and this mother will become type 2 diabetes. If we don't have a handle on this combination, we are in for trouble for the entire nation. Supriya, can you just confirm whether you're seeing my slides all right? Yep.
Yes, ma'am. Yes.
Yeah, thank you. So then the key point in the short-term obstetric management is to ensure the surveillance of the sugars in the mother with all its comorbidities and the growth and well-being, congenital anomalies, etc. of the fetus. Somehow you wriggle around for the good outcome in pregnancy at delivery, but as I said, again, I emphasize that when we say long-term, this mother may want to conceive again. So before her next pregnancy is also the continuum of care that you have to learn. Maybe you didn't have an opportunity to do the best with respect to sugars because she didn't show up earlier in pregnancy. But having had this taste of GDM and its complications in the first pregnancy, you must make sure that before she embarks into her second pregnancy, you get her to optimal weight, you get her to optimal glycemic levels, make sure that she takes folic acid, and then you have already created a platform for yourself for the best of the outcomes that you can have. So you will see the FOGSI leaders take on to the streets to say defeat diabetes and don't let India be the diabetic capital. And once again, I bring to focus that a lot of simmering controversy ended after the FIGO put forth a pragmatic guide for diagnosis, management, and care. Just let's take two simple case examples. Firstly, starting with obstetric management, what we should have done ideally pre-pregnancy. Already a known case of diabetes. She's very young, 24 years, BMI is 32. She's just recently got married. Luckily, the diabetologist who is seeing her refers her to the obstetrician. Obstetrician says, okay, when are you planning your pregnancy? Use contraception until you achieve an optimal weight. If she's a case of PCO, you just tune in the environment in an appropriate manner. And when you do her testing, both HbA1c, fasting, and ppbs, if the score is as indicated on this slide, you have achieved a glycemic control, you have done the expanded set of tests to know that, yes, now she has the green signal. She can embark on a pregnancy because she is fit to be mom, as we would call it. But the ground reality is either she doesn't seek advice, nor there is a cross-referral between the diabetologist and the obstetrician. Most often, as it happens, oh, doctor, I was not planning a pregnancy, but it is an unintended pregnancy. Then you just look at her HbA1c 8.8, fasting way above what Preeti said, 128, and ppbs she has scored a triple century as far as the post-prandial sugars go. There is seriously a threat of malformations in this scenario, and as an obstetrician, you and the couple are in a dilemma, and we are not supposed to be judgmental and say that the malformations will escalate. You should go ahead and terminate the pregnancy. This is often the question asked, but we are guarded in how we approach this answer, because we would say the facts that if the HbA1c you would have managed well before you enter the pregnancy, less than 6.2, 6.5, then the risks are as much as in general population. But if it's more than 10, then the risk is 25%. Also indicates that 75% of the babies are anyhow normal. So you cannot straight away as an obstetrician in your management say that you terminate this pregnancy. You would say that you wish you would have had a better control. But given the fact that gross anomalies like anencephaly, for example, can easily be detected in the first trimester and the counseling can be done with the transvaginal scanning, earlier detection of some of the anomalies at 12, 13 weeks and the NT scan itself is another clue for you to what to do further obstetrically. And put them up for an early anomaly scan, as has been already elucidated by Dr. Shah, that you will have your sense of direction with an evidence that yes, this baby is indeed a case of a gross anomaly, which would need further discussion with the obstetrician. 3 to 4-fold increase in congenital anomalies. That's why don't let the patient miss the bus, and do your best prior to the pregnancy. Folic acid, absolutely a must. Now, there's also a new guidance that high BMI, obese patients, instead of 4 milligram, they may require a 5 milligram. So that's also on the card. So you have to make sure that they would get the necessary amount of folic acid, because the neural tube defects, 1 to 2 per thousand in non-diabetics, 20 per thousand in those with high sugars. And this is really something which is an avoidable issue in the offspring, and we must pay attention to that. Again, a missed opportunity in between pregnancies. The first pregnancy, well, it was 11 years back. Government guidelines had not come. We all did not shout at the rooftop that you have to do a universal testing. So nobody may have done this testing for this lady who delivered a 3.9 kilo baby years ago. Now she's conceived again. 30 kilogram per meter square is her BMI. So you are now very religiously, diligently following the government guidelines. You say, I will do an early testing. And you've done the test at 12 weeks with the single step test, with the challenge with 75. And look at what her sugars are showing, 248 milligram%. And though you have done an early test, you've already missed the bus, because in the inter-pregnancy interval, she was not seen. So do not think that obstetric management is only when she has conceived or comes to you with the pregnancy. At every touch point, dear friends, at every touch point that a lady comes to you, pay attention to these things. Let it be at the back of your mind, and just don't blame her. Why didn't you come earlier? Because nobody told her to come early. So you will be in a constant roller coaster of dilemmas if the things are not done at the right time. So this is the entire protocol which has now been elaborated, and why the first trimester screening already we saw in the 2 cases that were presented. One of the most important things for obstetric management is to pay attention to the weight gain. And MNT, yes, it is a foundation, but many a times a mother-in-laws at home will say that, no, you're gaining weight very poorly. What does this doctor know? You must eat for 2 and this, that, and the other. But the weight column in these cases, normal weight, pregnancy weight can be allowed 10 to 12 kilos. This has to be restricted to 6 to 8 kilos. And sometimes even they may lose a little bit of weight or not put on from one checkup to another. No problem, because the entire span of pregnancy, they're expected to gain only 6 to 8 kilos of weight. Please encourage her. Throughout, everybody in your staff should ask her whether what is the kind of activity and exercises, because if you tell her your pregnancy is at risk, the common understanding is high-risk pregnancy, give her full bed rest. This is contrary to that. She must move around. She must walk after every meal. And that is what will get her sugars under better control. The scans, make sure they are done on time, because it may well change the course of the next part of the management of the pregnancy. And comorbidities of pregnancy-induced hypertension, gestational hypertension, which was the first part of the discourse this evening. Also, if there is a need to prophylactically start aspirin, as how the prediction and prevention of the preeclampsia and eclampsia and pregnancy-induced hypertension, the guidelines go. Often because it's a comorbidity, do not lose your chance to add on drugs such as these. As obstetricians, one main chunk in these patients is the glycemic control. Agreed. That has been very, very nicely elaborated. We are also worried about so many other things which can coexist with the patient, because to see that lady as a whole, every other patient is having anemia. So this patient also could be having undernutrition, by which we mean protein deficiency, because they're not eating enough proteins and B12. Pregnancy-induced hypertension, which I just said. Polyhydramnios, again, which is linked to the possibility of overdistension of uterus and premature labor. Inappropriate weight gain, delayed lung maturity, which we're all aware of, congenital malformations, not only first, second trimester, but some are going to evolve. So constantly it's worrying your mind about what you would find, and appropriate counseling of the time of delivery, mode of delivery, and most importantly, the place of delivery. Many times in rural India, now we are encouraging through the government for everybody to do the test. Then what? What will they do next? Because the sugars are haywire. We have taught them the MNT and metformin, and they managed to get it under control. But is it safe for them to deliver in a small little village, and then suddenly they have to shift the baby to a tertiary care center, long distances? So these things need to be planned. Today, the talk is for 15 minutes. Do remember, you need to probably spend 15 full minutes putting all the puzzles of all the pieces of the puzzles together for your head to turn around and decide what, when, how, and where. The most important finding in the scan, if everything else goes well, the tracking of the growth is large baby, but when the abdominal circumference is more than the 90th percentile, it's predicted that 78% of these neonates will be macrosomic. Why are we emphasizing on that? Because it rings a bell in your head for the mode of delivery. We know that there'll be a delayed lung maturity. That does not mean that all GDMs you will give the steroids for lung maturity. You will select, if you're sure that there are other reasons why you're expecting a preterm delivery, please go ahead and give the steroids for lung maturity, the 2 doses, 4 doses, as how it's outlined here. But be alert, and please let the patient not get psyched up. She has worked so hard to keep her sugars well. You're pushing this injection, and next she monitors at home or in the hospital. She knows that the sugars are going haywire. The stress that it creates is immeasurable. So alert her that this is a small temporary change for 48 hours, that we do expect that your sugars will rise, but we are giving you the steroid for the benefits for the baby, and we may need to increase your dosage of insulin if she's already on insulin. If not, 2 or 4 units of insulin are added for a temporary period. So prepare her from the beginning. That's one of the crucial, issues, because if she gets stressed out and the sugars escalate because of that, which is a very well-known fact, you are in for trouble, because so far you have managed her glycemic status to the best of your capacity, but you may lose track of that. Timing of delivery. Yes, theoretically, a well-controlled diabetes with a reassuring fetal condition, expectant management, but not beyond 40 weeks. You can't allow these women to go post-dated, that's for sure. Sometimes we may have to intervene at 38 weeks, where we are sure that you're not too early and you don't want to wait too late. These are the situations typically where there has been a previous stillbirth, diabetic nephropathy, vasculopathy, which is implying that major organ damage is progressing and you need to intervene a little bit earlier than term. Poor glucose control, of course, whatever you're doing, it is going to not come in your clutches. Then you rather act safe than sorry by delaying it. Any other obstetric indication, of course, you will take action at 38 weeks. The macrosomia is one thing which compels the obstetrician to be in a dilemma. Should I allow a vaginal delivery or not? We know that if sugars are normal, if you're expecting a reasonable sized baby and she has a roomy pelvis, you would, of course, want her to have a vaginal delivery. But the way the family has struggled and you have struggled throughout, sometimes there is a gray zone, sometimes there is unpredictability. And when you're quite clear that within your population, it is crossing the 90th percentile, need not always be 4 kilos. Average in your unit is about 3.2, 3.5. This is showing anywhere 3.8, closer to 4. Then you know that you may have to err on the safer side and have a little more liberal policy towards C-section when macrosomia is suspected. Because when within the short phase of a vaginal delivery, you get into situations like shoulder dystocia and then say, oh, I knew this would happen. And shoulder dystocia can be expected, but can never accurately be predicted. Drills to be conducted in non-crisis times with doctors and non-doctors. We may add on this as a special module in Manyata as well. One clinical leader to make decisions and coordinate the activity, because you know it's shoulder dystocia, but the team is not used to managing it for vaginal delivery. And please beware that the maternal trauma is a huge issue with vaginal cervical injuries, anal sphincter damage. Even during the C-section, there could be operative difficulties, and hemorrhage and hematomas are common. Infection is, of course, looming large because of the high sugars. Sometimes you'll need blood transfusions, prolonged hospitalization, fistulas, and whatnot. So it is not only that you manage the pregnancy on a tightrope, but even at delivery, there could be a number of issues. If she lands up in a spontaneous labor, because you're waiting for her to be in spontaneous labor, sugars are well controlled, she's only on diet, admission CTG, plot the partogram, sugar to be tested 4th hourly, the target levels 80 to 110 milligram % in that range, and where the facilities available, continuous fetal monitoring. If she's posted for an elective section, especially many of the cases where they're on insulin, if we post her for the elective section, she has to be nil by mouth, omit the morning dose of insulin, sugars and serum electrolytes to be done, post-op blood sugars to be checked every 2 hourly for the first 12 hours, and 4th hourly after the patient starts the oral feeds. Plain insulin according to the blood sugar sliding scale, or if she delivers in an institute, of course, you have the luxury of a diabetologist, you can always take his advice and see what next to do. Most importantly, in the obstetric management, never to forget that the baby can now have hypoglycemia, and the sugar should be checked at birth and 30 minutes, 1 hour, 2 hours, 4 hours, 8 hours, 12 hours after birth. And all the time the staff should be alerted to observe clinical signs. Early breastfeeding should absolutely be encouraged. And sometimes we need to start them on IV glucose as well. Long-term problems of neonatal hypoglycemia could be cerebral palsy, epilepsy, cognitive impairment, visual problems. So these are, the developmental and behavior disorders completely washes away the kind of care that you have taken throughout. The last thing I would like to say is pay attention. She is today diabetes in pregnancy. This should not progress to diabetes after pregnancy. She may not wish to conceive ever again, but she must see you every year. After the postpartum check at 6 weeks is over, don't reassure her very convincingly that everything is well and now the worst is over. Keep her on the alert so that she comes every year, and this will ensure that as we walk towards tomorrow, we will be able to gift the next generation with good health, free of NCDs. So with this, once again, I emphasize pre-pregnancy management as an obstetrician. It's entirely our responsibility, especially the opportunity available at fertility centers where they are available, a catchment of the target couples for the pre-pregnancy care. During pregnancy, there are a lot of issues that we have to pay attention. So we need time, and please empower your staff to do a thing or two with each and every patient, motivating them to be compliant to the regime that you have outlined, and extra alert with the expert team of pediatricians and the paramedical staff at delivery. And don't forget about her forever after in your life and her life. With this short presentation on obstetric management, hugely challenging, but there are huge number of opportunities for us to do our best. I can see Parag and Sarita on the very warm hello from my end.
Thank you very much, madam, for your wonderful, and it's a very informative talk and detailed of each and every step, what has to be done, and all the do's and what to do, what to not to do. So thank you very much, Hema ma'am, and we really love to hear you always. Thank you so much.
Thank you.
So with this, we come to the end of the second session, and we start with the panel discussion. So we have case-based panel discussion on HIP. So the moderators are Dr. Sarita Bhalerao, madam, and Dr. Charmila ma'am. One second. So Dr. Sarita Bhalerao, madam, is she is the President MOGS at present, And she is also the past chapter secretary, IMS, member of Governing Council, ICOG, and many things to her credit. So Madam is a fine obstetrician gynecologist to Beach Candy Hospital, Reliance HNF, Bhatia and Wadia Maternity Hospital. So welcome you, Madam. And the next moderator.
Thank you, Dr. Supriya.
Thank you. Welcome, ma'am. And the second moderator is Dr. Charmila Ayavu. She is the Vice President-elect FOGSI at present, and she's the chair. She had been the chairperson Clinical Research Committee of FOGSI 2016-18. Madam is also the ICOG Governing Council member till 2021-23, and a very, very academic person. So we have a galaxy of panelists. We have actually few have sent their apologies, but I start with Dr. Vijay Lakshmi Sheshadri. She is the senior consultant of Sundargram Medical Education, Chennai, and she is at present president of OGSSI 2021, past executive member of TNFOG. Then Dr. Welcome, madam. And then Dr. Tabassum Dalla. She is the president of Raipur Obstetrics and Gynaecological Society and vice president IMA Raipur. And she is a very academic person. Okay, welcome. I welcome you. Then Professor Dr. Sarita Agarwal, who is the professor and head of Obstetrics and Gynae Dean Research All Institute of Raipur. Then contribution, she has been vice president of FOGSI 2015. Then ICOG Governing Council member, ICOG Academic Council member, chairperson HIV Committee FOGSI, and she has been credited with many awards. Welcome you, madam. Dr. Umayal Murugesan. She is, madam is also obstetrician and gynecologist, laparoscopic and infertility specialist. She is a wonderful human being and has been awarded with many awards. And she is the founder secretary of Kanchipuram Obstetric and Gynaecological Society. Welcome you, madam. Now, Dr. Ritu Khanna, ma'am. She is at present chairperson of FOGSI Food and Drug Medical Surgical Equipment Committee. She is a very active member and very knowledgeable, very good orator, and working as executive single embryo transfer, exclusive single embryo transfer. So, madam, we welcome you, and over to the moderators for the panel. Over to the moderators.
Yeah, Dr. Charmila, you want to start or should I start?
No, it's yours first.
Okay, so thank you very much. And at the outset, I must thank ICOG, Dr. Lakshmi Srikhande, Dr. Parag Binewale, and Dr. Sneha Buyar for giving us this opportunity to conduct this panel. I've been listening to the talks and I really think they've been fantastic. So we are going to now go into a very practical case-based discussion on diabetes and pregnancy. So my first case is Mrs. SS. She's a 35-year-old patient, conceived spontaneously. Her weight is 80 kg, height 5'2", BMI of 32. Family history, mother is diabetic. She came for ANC registration and her HbA1c was done, which is 6.9, fasting sugar 92 and PP sugar 103. Can I have the next slide? So my first question is, how do you define GDM? I think, Dr. Charmila, that I had written the names of the people, that somehow that is not seen.
For the first case, you put Dr. Sambat. I think she's not joined.
That's why. Yeah. Oh, that's why. Okay.
I think Dr. Peaky was there. I think that's the reason.
Yeah, doesn't matter. So we can start, and I can ask, let me start by asking Dr. Sarita Agarwal, how do you define gestational diabetes?
Madam, please unmute.
Yeah, I think let all the panelists unmute.
Yeah, regarding the definition of GDM, I think very well discussed earlier also in these presentations. And whenever you get like we are following the DEPSI guidelines. And according to that, if I get a blood sugar checked in the first visit and then repeated 24 to 28 weeks. And if I get a blood sugar 2 hours after the 75 gram glucose to be more than 140, we label these as a GDM.
So basically, it is diabetes which occurs for the first time in pregnancy. Would you agree with that?
Yeah, definitely.
Yeah.
Actually, Dr. Sarita, I just want to clear my confusion about this also. You know, when we used to read earlier, it is a diabetes which is diagnosed for the first time after 24 weeks of gestation. Then we used to label it as a GDM.
Absolutely.
And before that, if we have, then we label it as a pre-diabetic, which is diagnosed first time during the pregnancy, or the women may be non-diabetic on that condition, you know, because our management is discussed extensively. If it is developing for the first time after 24 weeks, it is exclusively an GDM. Of course, before prior reports should be there where the sugar levels were normal. Because the outcome in the GDM is much more different than the pre-diabetics or the over-diabetics.
Absolutely. Let's go ahead and I'm going to ask Dr. Vijay Lakshmi, why is pregnancy diabetogenic? Can you tell us very quickly?
Yeah, one is there is definitely a higher insulin resistance during pregnancy, and definitely all the placental hormones which are secreted, and that is where they contribute to the diabetic state, and that is why pregnancy is a diabetogenic state. And what happens is once the cycle sets in, because it is going to give a huge placenta, again this goes in for the secretion of even more placental hormones which are going to be diabetogenic and contributing to this. And definitely all these are risk factors for the pregnancy going in for diabetes. Of course, we know all the risk factors where we have certain races which are prone, including our Indian race. And we also know that these are the people who are going to get because of higher risk factors. And so we all know that the pregnancy diabetes or the hyperglycemia in pregnancy going to be a little more in these pregnancies.
Yeah. So let's go ahead now and let me ask our Dr. Umayal. Dr. Umayal, are you there? Can you put your video? Yeah. So what I want to ask you is that what is the approximate incidence worldwide and in India? And I was listening to Dr. P.K. Shah, who was saying that India is a diabetic capital of the world. So do you have any estimates about the incidence?
Yeah, roughly our incidence of GDM in our country is somewhere between 5 to 15%. So we should, each one of our patients, as soon as they come in, I usually want to do my sugar test as soon as the patient enters. So when I do yeah.
Okay. And is the incidence increasing in your practice? What do you think?
Yes, madam. So as I do the test as soon as the patient enters, I am identifying so many patients who are already diabetic, very young and diabetic, then getting pregnant. And for the first time, we are identifying diabetes in them. So it is very essential for us to identify whether she's a diabetic or she's a patient without any hyperglycemia, but going to become a GDM patient in future is very, very important step in the management of these patients, madam.
Okay, Dr. Tabassum, what are the risk factors for gestational diabetes?
Any patient who is obese, then less physically active, or the patient had pre-diabetes, or the patient had diabetes in her last pregnancy, I mean GDM in her last pregnancy. Any patient who had polycystic ovaries, then she may have a higher risk factor of GDM. And any family history also would also contribute. Family history of either GDM in her mother or sisters, or diabetes mellitus in parents, or any other first relatives of her.
Yeah. Also, I think previous macrosomic baby, that would also put her at high risk for diabetes. Have we left out anything? I'm asking other panelists, Dr. Charmila, have we left out any risk factors?
No, I think most of, and that family history is the most important in our country.
I think Dr. Sarita, being an Indian itself is a risk factor. Asian women are, yeah, that's very important.
Yeah. So let's go ahead and we come now to screening. And I'm going to ask Dr. Vijay Lakshmi. I think it's beyond doubt that we screen all pregnant women. Yeah. We're not going to screen only on the basis of risk factors. So let's leave that question. But now let's go on to, in your practice, how do you screen? Which screening test do you use?
I use DIPSI guidelines. because it has been universally accepted now. WHO has accepted, FOGSI guidelines have accepted. So we use DIPSI guidelines for screening, where we fasting or non-fasting, we give 75 grams, and then 2 hours later we do blood sugars, and if it is more than 140, it is considered screen positive. And of course, we can then follow it up with OGTT or whatever if it is negative. Now, if suppose the patient vomits, which is, I mean, this, of course, this sugar needs to be given in 300 ml of water and over about 10 to 15 minutes. And if she vomits, and if vomiting happens early, less than 30 minutes, then we are supposed to redo the test the next day. But suppose she doesn't vomit for 30 minutes and then because it's very common in the early gestation that she can have nausea and vomiting. And if that happens, then we can go on if she's vomiting after 30 minutes. So that's a usual protocol. But of course, some do not, I mean, they do get into fasting. There are people who are also managing with other kinds of screening tests with fasting and then 75 gram OGTT and then 1 hour.
So let me now ask the panelists, is everybody using the same single stage screening test, or does anybody use any other? Dr. Umayal, Dr. Tabassum, Dr. Sarita Agarwal?
We at Raipur, most of us are using single step DIPSI, 75 gram 2 hours.
Okay, so I think that.
Yes, madam. We also use the single step test as soon as the patient comes and confirms the pregnancy.
Now I'm asking you.
Rule out. Yeah.
So now the patient, this patient that I had given you has booked at 11 weeks. So will you do it at 11 weeks or will you do it at 24 weeks? When would you start doing?
Sarita, what you have presented is already HbA1c is quite high.
Yeah. But suppose she was not. When would you do the screening test?
I will always do the moment she presents to me because it's very important to know even in her first trimester. How we follow up, suppose it is negative, then of course we can do a repeat test at 24 to 28 weeks as a screening if she doesn't have any other contributory factors. But if she has, then definitely we will do it earlier and 24 to 28 and then in the third trimester at 32 to 34.
So you will repeat this oral test twice, once at booking and once again at 28 weeks.
In the last trimester, that is where if it's so delayed, the first time appointment happens with us only at the third trimester, which is, I think, a little rare because nowadays everybody is testing. So somewhere she will have the results, whether we believe that result or not, but she will have some results.
Okay, Dr. Sarita, my question to you is, what is the value of HbA1c in pregnancy?
Yeah, that's cutoff which we take for the risk of the congenital anomaly scanning. It's very clear. If the HbA1c is less than 6.5%, the risk of anomaly is less than around 5%. But if it is more than 10%, the risk increases up to 25%.
Yeah, but I think that is for an over-diabetic who enters pregnancy, and Dr. Charmila is going to discuss that case. My question is, here we have a patient. What is the value of HbA1c in monitoring sugars? Is there any level of a screening for diabetes?
As of now, the screening for the HbA1c base is not been recommended. And at 11 weeks, if I go, I'll go for the adult level for the HbA1c. I'm not going to take it as a pregnancy, induce some variation in the HbA1c.
Yeah.
Of course, if I'm looking for the HbA1c at 28 weeks, then my values may be differing as per the pregnancy.
Okay. So I think that there are pluses and minuses. Yes.
Add just one thing, because in pregnancy, there is a possibility for a dilutional anemia. And that is why we don't consider HbA1c in pregnancy as a guideline for monitoring. But definitely an initial high level may predispose, or even between 5.7 to 6.5, we may consider that she was pre-gestational.
Okay.
If she has reported late to us.
So I'm going to ask this question to any of the panelists. What is the HAPO study, since it's such an important study? So Dr. Tabassum, would you like to take that? Or Dr. Vijay Lakshmi?
Yeah, it was hyperglycemia and the poor obstetric outcome study. And that is what guided people to really link the obstetric complications to the hyperglycemia. And it did show that we need to really get into the details of her obstetric management in a better way. But I think again, individualized management of the cases have come. So this, though HAPO study is a very important study, but I think
now we have many more studies.
Yeah.
So Dr. Charmila, let's go ahead. And the next question, I think Dr. Sampath is not there, so we will ask other panelists. Here, this patient had a 75-gram GCT done and her post-glucose blood sugar is 160. And she comes to you with a report. Dr. Umayal, would you like to take this? What are the maternal risks of GDM, both pregnancy-related and long-term?
Yeah, once the patient is one second.
Yeah, sure.
So once we know that this patient is now at risk of GDM, then we will have to start discussing the management with her. We will have to tell her the risk of GDM. We will have to counsel her properly as to what all could happen in the next 8 to 9 months. And so the weight gain has to be discussed with her very, very clearly, and the strict control of blood sugar, her diet, and her exercise.
I think we'll go into all that, but first thing the patient says, but so what can happen to me? What is the is the risk?
So definitely, if she's going to become a GDM, then all the complications like polyhydramnias, like preeclampsia, and increased weight gain, all these things are going to be a part of her pregnancy. So we'll have to, and also increased risk of cesarean section.
Absolutely.
And new maternal morbidity and newborn morbidity also has to be explained to her.
And the long-term risk?
And also the need for more frequent checkups. And the long-term
the long-term risk is like she's a potential patient to become a diabetic patient in near future. Next.
I think we haven't asked Dr. Ritu Khanna anything. Dr. Ritu, because I can't see your video. Can you put your video on? Sorry, I didn't realize you're there.
So we had in the puerperium also, we need to be careful. She could have infection. She could have lactation failure. She is more prone to instrumental deliveries, more traumatic deliveries, and PPH and maternal mortality, morbidity also. And if you go into the long-term complications and weight retention, GDM in subsequent pregnancy that we need to counsel her, diabetes, cardiovascular diseases and all, madam.
And what are the fetal risks?
A fetal is more prone to stillbirths if she goes uncontrolled, neonatal deaths, congenital malformations, then chances of certain shoulder dystocia, macrosomias, then the babies are prone to hypoglycemia, hyperbilirubinemia.
Now, are these GDM patients more prone to have congenital anomalies, yes or no? What would you say?
Yes, madam. If she had a uncontrolled HbA1c, then they are much more prone to having.
So it is basically for pre-existing diabetics, not for GDM. That is the thing. Yeah, Dr. Charmila, let's move to the next slide. And we now come to the role of nutrition. And this question is for Dr. Tabassum. Can you give us some simple clinical pointers on ideal weight gain and how nutrition can benefit this patient?
Nutrition plays a very important point in controlling her GDM, and nutrition should the aim of the nutrition is very important. She should have a calorie intake which suffice both mother and the baby, and she should not go into ketosis also. So we have to think about the baby, the mother, and the optimal fetal growth. Sometimes the baby may also go in IUGR if you're giving an insulin. So we have to be very careful in maintaining her sugar levels. So definitely nutrition has got a big role. Ideal nutrition would be a very low carb and high protein diet for GDMs. And ideal weight gain normally in the pregnancy is around 11 kgs. But then if she is already obese, we restrict her to around 8 kgs, not more than 7 to 8 kgs.
Yeah, so we have recommended weight gains in pregnancy, as you said, and if they are normal BMI, then it is 11 to 16. But if they are overweight, then maybe 7 to 12, or if they are very overweight, more than 30 BMI, then only 5 to 9 kilos. And can you tell us some simple practical points? I think I'll ask Dr. Sheshadri this, that how will you give, what diet tips will you give?
Yeah, I will tell you that we cannot really restrict carbohydrates like how we do for the non-pregnant patients, because baby still needs direct carbohydrates.
Absolutely, yes.
On sugars, because sometimes a family consult comes and then they say, oh, you're eating so much of carbohydrates. We know that we need to give her a plate which will direct accordingly, and about 50% or rather 45% of that needs to be carbohydrate, and then the remaining can be divided as 25 and 24 between the fats and the proteins. And we need to give her a complete list based on her own way of diet pattern. You cannot impose something which is not going to cook at home or going to eat.
Very true.
You need to first ask her, what is your routine? What is the cooking which is happening at home? And then we tell her a little bit about these high glycemic, low glycemic index foods, so that, you know, she does not take complex carbohydrates and she's on simple sugars. And that is where, I mean, if you give complex carbohydrates, it will absorb slowly, and also add on with fibers, which will absorb slowly as well. So that is how we will have to educate and then give her a complete list of what she should take. I would always involve the dietitian and tell her, this is the weight gain, this is what we expect, this is the sugar, and control, not control on whatever medication, and then give her a list. You must eat this or this or this or this. You cannot take every day you eat chapati, every day you eat idli. Is not like that. So we have to give her a choice and then form her complete dietary thing. And important is that she keeps coming to us repetitively for this, because her needs will be different as she grows, and otherwise she will be also, because as somebody had put earlier also in the chat, that more than macrosomic babies, nowadays we are seeing smaller babies. So maybe she does too much, and then it is going to be a growth retarded.
So I think that one of the very important things is that glucose is the main substrate for fetal growth, and we need that baby needs that glucose. And I was at a conference, Dr. Charmila and myself in Bangalore, and they described how the 8-inch plate should be taken. Very simple. Half the plate should be carbohydrate. The other half should be divided into 2. So 25% forms fiber in terms of fruits and vegetables, and 25% should be protein. So if you, this is a very, very simple way of giving, you know, letting patients eat adequate amounts of diets. Also, what about the meals? Dr. Sarita, would you like to say anything about distribution of the meal?
Small meals, frequent meals.
Yeah, that's also true.
And they need to take the meals on time, madam, because
Absolutely.
we need to stop the insulin spikes. So they need to have it on time.
Absolutely. Dr. Sarita?
I really want to add something on that, because nowadays I'm facing a problem of having SG and FG are more prevalent in women who are the GTM, and it's over-treated.
Yes.
The reason for that, the nutrition cutoffs are too much in these ladies, right? So what I'll suggest on that, what we do in that, that when we send the patient for the dietitian to calculate how much calories she should take, then I think we should take the pre-pregnancy BMI, and accordingly we should tell how much calories she should take. Then what happens, they don't add the additional requirement during the pregnancy. And at none point of the time, they should be having the calorie less than 1600 kilocalories per day. So this, if you are going to follow, it's like if I'm calculating the pre-pregnancy BMI, which come to be 1400, then I have to add 300 kilocalories as per the pregnancy requirement, as per the gestational age of the mother. That is how we are going to calculate the calorie. Then second, come to the how frequent meals are important. So this is very important. The pregnant diabetic women should have the 6 times meal follow-up.
Hello?
That is 3 major meals.
Can you hear me?
Yeah. Yes. Sarita.
Yeah. Okay. I think Dr. Charmila, let's go ahead.
3 major meals and 3 minor meals are very, very important. And then the minor meal should be half of the major meal. So that way the calorie distribution has to be calculated. And the total calorie has to be calculated very nicely based upon a pre-pregnancy BMI, not for the current BMI.
Absolutely. Yes. Dr. Charmila, any inputs from you?
No. As you said, that plate seems to be very important, because it's very easy to counsel the patient showing the plate, how the food is taken, because most of the times if you're trying to tell them major meals and minor meals, like how much they understand in our population is a little difficult, but show them the plate, tell them to take a picture of that, and it's all put up, the food there which needs to be taken. That seems to work much better.
Absolutely. So let's go ahead, and Dr. Humayal, this is over to you. This patient was started on metformin 500 milligram SR after lunch, and her 28 week sonography showed polyhydramnios. Pre-meal sugar was less than 100, but post-meal was 150 to 160. So now my question to you is, which oral hypoglycemic do you prefer? What is the safety profile? Any risks? What would you like to, what do you practice?
So actually, like initially when the patient is showing signs of diabetes, then what I do is like I put her on a oral glycemics. Mostly it is metformin, which has been proved very, very safe for all of them. So here we, depending upon the glycemic, the blood sugar levels, we can start it from 500 milligrams to 1000 milligrams in divided doses. But we should also have a strict control on the blood sugar level. So whenever she's going to see you, I always tell my patient, do your fasting and then with your medicines, do your postprandial and then come and visit. And if she is able to maintain it less than 100 and in less than 140, it's fine. But once she starts overshooting, then probably like I would have already counseled to her about insulin. So most of these patients, initially they start with metformin, and as the pregnancy gets advanced, they are put on the insulin doses, and together we are able to get a good glycemic control. The basic
any risks of metformin? Any downside to starting metformin?
Metformin, yeah, sometimes patients are not very happy with it. They have gastric distensions, they have stomach upset, loose motions and all that. But if they are not really with they are not happy with metformin, yes, we don't give that, but that is a very rare case. Mostly these patients, and most of these patients nowadays are PCOS patients, and they have already taken metformin for some time. So,
but tell me, do you have patients who complain that their appetite is gone after metformin? Anybody on the panel? Because this is what I have seen, that their
bloating,
appetite goes.
Many times they say complain of bloating, and they say that their stools, many people have complaints with stools. We pass motion 2 to 3 times. I feel very tired and all that things. So, but with insulin, we don't see any of these things. So
okay, let's go ahead. So let's go ahead now and say that this patient was not well controlled on metformin alone, and therefore it was considered to start insulin. And my question to Dr. Ritu is that at what point will you consult an endocrinologist?
Yes, ma'am. So number one is, if the pregnancy is less than 20 weeks, we would like to opt for insulin. And the second is, if there's need for any pharmacological therapy to be added after 30 weeks. Thirdly, if she was on a medical nutrition therapy or any other therapy, but the fasting blood sugars exceeded 90 milligrams, or the 2-hour postprandial was more than 120 milligram per deciliter. So these were the indications where I would like to switch her onto the insulin therapy. And
will you do it yourself, or would you refer to the endocrinologist?
I would like to be under our control and also the endocrinologist, because we need to calculate the dose, because first 1 to 13 weeks, we need to add it as 0.7 into weight in kgs, and 14 to 26, it is a little more, it's 0.8 into weight, and 27 to 37, it will be 0.9 into weight.
Oh my God.
38 weeks, it will be 1. But when it comes to lactation, again, I need to be in touch with the endocrinologist, because the requirements are going to decrease. So they're going to come to half. So it's going to be 0.5 into weight and body. Then
so I think most of us consult endocrinologists. Is that correct?
Yes.
Yeah. No, Dr. Charmila is saying no. Dr. Charmila, you're managing the insulin yourself?
Yes.
Yes. So now you tell us, how would you start?
See, that dose, that 0.7 dose seems to be very high for a GDM patient. So there's something which Stephen Gabay, he's put up a regime where he puts 444. And Dr. Muralidhar Pai also says something like that. That is, you put at a lower dose of insulin.
So plain insulin. This is plain insulin, 4 units. Actrapid before breakfast, before lunch, before dinner.
And we check the sugars every 3rd day fasting and 2-hour postprandial. And it's like we change the meals, because they're not happy with checking 6 or 7 times a day, as the American college says. So we tell them every 3rd day fasting and 2-hour postprandial. And after a week, you call them with the reports. It seems to control much better than, because there's a tendency for hypoglycemia when you start at the diabetic dose of 0.7 or 1 milligram per kilogram body weight, because that seems to be too high for GDM patients, I say.
Yes, yes. That's so you don't tell your patients to do SMBG at home, do you?
I tell them to do that. We teach them how to do with a glucometer, and we tell them the levels also, because it has to be a self-control. You cannot control her every day. So she has to change her diet according to what her levels are. So we teach them the target levels which she needs to maintain throughout a pregnancy.
See, if we can have a little bit of understanding of these types of insulin and the way they act or the duration and, on.
Madam, for GDM, you need not break our heads regarding what type of insulin, because most of the time
it is
the
very
NPH
simple,
or short acting is
simple
quite easy.
4 unit, like how it is given in FOGSI guidelines also. It's very simple. You start with this sugar and add 4, then do the fasting level. If it is a little higher, then you do the pre-dinner, you increase the dose, and the mixes, mixed starts are good because they are pre-mixed. And then if it is a little fasting is high, then you do that. But if it is postprandial or preprandial, which is high, you increase the morning dose. So I think it is not very difficult to titrate these doses. And with practice, it is much easier to simplify with 4 unit, 2 unit, add 2 units.
Because she going and sitting at an endocrinologist or a physician's chamber is very difficult for a pregnant lady. So most of the times because my husband is a physician, but still
that's why you know how to do it. That's why you are able to do it.
But I still,
that's why she will not know.
Once consultation with the endocrinologist, and sometimes we just put all the charts over there, so that if she increases by this much, she can add so much of it.
Okay. Let's go ahead now, Dr. Sarita. And my question to you is, what about obstetric management? And can you tell us about antenatal monitoring of these patients?
Yeah, I think you have given some good things on the slide. I should go one by one. Regarding the endocrine referral, yes or no? So to be on the safer side, you can have the endocrine referral, but if you're a good obstetrician, know how to do the GDM management, the obstetricians are better in managing. Of course, when there's a fluctuating level with the insulin, then you should always take a consultation with the endocrine, first thing. Second, about the self-monitoring of blood sugar, yes, it is very, very important to have a self-monitoring by the patient herself, because then only she understands how it is going to be monitored. And when the patient comes with the chart prepared at home, she realizes every sugar tells her, yes, there is something going wrong with her, and she becomes more adherent to your treatment protocol. Therefore, the self-monitoring to be taught. Then how often self-monitoring of the sugars? Of course, when you start first time diagnosed, you admit the patient, monitor the sugar levels, and then you start either OH or insulin. And once the sugar levels are normal, then you can go home and do the self-monitoring. Then how frequently you should monitor sugars at home? For that depends. If it is a well-controlled, you achieve within hospital. In that case, the monitoring can be a simple fasting sugar one time and a postprandial 1 meal only. But if she is on insulin therapy, we can ask to get at least 4-time charting, that is fasting and after each meals. And that maybe if you're finding it is well controlled, then the twice a week monitoring may be sufficient. If not necessary, then she should monitor daily on that way. But of course, if she has some complications, the sugars are not well done, then the daily charting may be advised. Coming to the what target level she should maintain. So as per the ICOG recommendations and all other body has adopted, the fasting blood sugar should be less than 90 mg/% and the postprandial 1 hour should be less than 140, and the postprandial 2 hours should be less than 120 mg/%. But I just have some queries about these target. When you talk about less than 90, less than 120,
very less, yeah,
or less than 140, we don't give the lower limits. We get the patient, they have the sugars falling in between like 60 and they are asymptomatic. Maybe having the 70, she's asymptomatic. And that case, what happens is babies, rather than developing the macrosomia and the LGA, they develop SGA and FGRs, which is also a concern for us. So I feel the target level should be in dash. It's like not less than 90, less than 140 or less than 120. It needs to be defined how much it should be. So as per my practice, I never let any sugar values to go less than 80 mg/%. So that is one target. Then how often I discuss. Then about the fetal monitoring, it is very, very important to have the fetal monitoring. Of course, regarding the anomaly, the early anomaly scan and the late anomaly scan. And the fetal echo is always advisable like 22 to 24 weeks. But nowadays with a good resolution, with an overt diabetic can get a fetal echo even early at 18 to 20 weeks. So that is one thing. Then about
Yeah, I think we can move ahead now.
and just one more
Yeah,
thing.
yeah, go ahead, go ahead. Okay, you can finish the obstetric management, then we'll.
Yeah, regarding the growth monitoring is again important. After 32 weeks, you have to look for if there's a macrosomia or the LGA or even SG and FJ is very important. We should give an attention to that thing. And then the fetal well-being, the NST and biophysical profile also, they do have role after 32 weeks in the high-risk group, and the low-risk 36 weeks onward, you should get a weekly NST and the biophysical profile.
Thank you, Dr. Sarita. So, Sarita, shall I continue?
Yes, please.
Yeah, okay. So the wonderful inputs from all the panelists. I think we are learning a lot today. So this patient is I'm just putting a case scenario. This lady is 33 years old, has had irregular cycles, married since 14 years. She's married to a maternal uncle. Obstetric history, she had an infertility conception in the first pregnancy. Yeah, and the preterm cesarean was done for severe PIH, and that was 7 years back. And she had actually delivered a live male child, a smaller baby, but is doing quite well. Now she has come with a spontaneous conception, and she comes with 2 months of amenorrhea. Evaluation BMI is 28, blood pressures of 120/80. She's got a live fetus of 6 weeks, 5 days. Sugars done along with the other investigations. Screening showed 280. Subsequently, an HbA1c was done, which was 10.3. So, Dr. Sarita, I'll take up with you because you're talking about SGA and vascular changes there. So 10.3, any special advice? Are you going to ask her to terminate? What is your thought on that?
That is very important because the HbA1c is more than 10, the risk is 25%. Here comes the role of the good counseling. See, the risk is 25%, means 75% are not going to have any problem. But which 75% we don't know. So it is very important we should sit with the patient, do a counseling and tell all the risks associated with. And then it is always better ki, of course, we have to respect the patient's opinion, but considering the risk to be 25% anomaly, it is and she has already 1 baby. So
Okay.
she can opt for termination of pregnancy in this case.
So
but
no,
if at all she doesn't want, it is very important, and we should let her know the importance of early anomaly scan, late anomaly scan, and fetal echo. And despite of that, it should be told very importantly that despite of all this monitoring, the baby can still have some anomalies which cannot be detected.
Okay. Tabassum, she wanted to continue with the pregnancy. How are you going to manage? How are you going to counsel her, and what are the points you're going to tell her at the first visit? Dr. Sarita has already covered that, but with a HbA1c of 10.3, what are you going to do now?
She's already 10.3, so she still may have possibility of anomaly. So I would tell her that there are possibilities.
No, we have told everything she wants to accept at whatever risk, because this is a very precious pregnancy, even if she's had 1 child.
Then she should have very regular testings. Her insulin levels should be, her sugar levels should be in target. A proper target should be maintained, and she should undergo fetal echo at 24 weeks. And also she should undergo a very detailed anomaly scan at around 20 weeks so that we pick up anomalies very soon. And also we can also have an early anomaly scan at around 14 weeks.
Forget we have told her that she needs to go for repeated scans. That is because it's the first visit. We have told her about the cost factor and what all she's going to and all that. But what about the maternal condition? What are all you're going to test before she continues her pregnancy?
We have to test for her, her fundus examination should be done, her renal profile should be done, and we should assess her obesity profile. How, we have already mentioned, I think she is obese, her BMI is 28. So we should also assess her, and we should tell her to have regular exercises. Apart from that,
Tabassum, you are not getting my point. See, Dr. Sarita has already said, this lady has got a HbA1c of 10.3. You have counseled her totally. Abortions, anomalies, fetal testing, all that has been done. And now you're going to go ahead, and because she wants to continue the pregnancy. You talked about the financial aspect, because this is going to be a costly management because she needs to have so much of medications. But the other thing is her target, I'm asking, like we already told about the sugar control or weight control. You need to see what the maternal condition, her eyes, her kidneys, her heart, all that also be checked. Because suppose she's got a retinopathy there, or she's got something like a renal damage already happening, that's going to cause more problems to you. So all this you test, and you test for thyroid also, because many times you will have thyroid dysfunction along with the hyperglycemia also. And tell her, she should have had a goal of 6.5, which has not happened. So it's going to cause problems. So how are you going to manage? Because I'm not asking the management, the aims
Dr.
of therapy.
Charmila, can I interrupt over here for a while?
No, 1 second, madam. I'm just asking Tabassum. Like, what are the aims of therapy? I'm asking. Like, what are you going to tell her? Like, like madam has already said, Dr. Sarita Garwal has already said, she's going to manage the fetal part. But you have to tell her about something basic because she needs to undergo all that. And she's not ready to do all that. It's going to cause more problems. That's what I'm asking.
Yes, she should maintain her target levels, less than 95 fasting and 1 hour 140 and 2 hours 120. Apart from that, she should maintain her diet properly so that she does not put on excess weight.
Yes.
Then she should also go on go ahead with her all medical managements like ophthalmologist opinion should be taken, one cardiologist opinion should be taken, and a nephrologist opinion if her kidney functions are not well.
Yeah, okay. Yeah. Dr. Sarita, what do you want? Please add.
Yeah.
Dr. Sarita wanted to say something.
I just want what Dr. Tabassum has said, it is very, very important that the overt diabetic should get this evaluation done. It is always better to have a physician opinion, endocrinological opinion. And if there's any nephrological condition which contraindicates for continuation of pregnancy.
So whatever we said, you're agreeing.
Retinal changes on that pregnancy continuation is not advisable on the point of maternal risk. She should understand that thing.
Okay. So and actually when you yes, please.
Okay, continue.
Yeah. See, what actually wanted to like tell her like the diabetic pregnancy you're having going on with the HbA1c, you're told about the fetals, tell her the aims of therapy should be to prevent a perinatal death. So everything is oriented towards that. So the maternal control is very important and the fetal condition has to be checked often. That's what you're going to tell. Then tell her she has to undergo an intensive insulin therapy. It's not going to be as simple as in a non-pregnant state. And she has to continuously self-monitor herself because she needs to check herself almost 6 to 7 times a day. All this she has to be ready for before you start managing when you've seen a HbA1c of 10.3.
One more thing need to be added, aggravation of maternal risk also to be added. You know, if the woman is still desirous Pacella-White classification, she is at risk, then the monitoring is very, very important. She should understand. So prevention of maternal complication is again very important because she's at risk of having UTI, pyelonephritis, appendicitis, so many things, you know.
Okay. Yeah. So suppose she is a type 1 diabetic, what will be your mode of management? Dr. Vijayalakshmi ma'am?
Yeah, I think this patient with such high sugars, I will straight away admit her, keep her under observation and go ahead with insulin therapy.
Drug is insulin. Drug is insulin. Yes.
Straight away insulin. And the insulin therapy, I will rather put her on either I can go through all these types of insulin, or else I can give her directly morning. I mean, after checking the sugars, either we can put her on regular insulin first.
No, I'm not asking the regimes now, madam. Type 1 diabetic, you said insulin straight away. Type 2 diabetic, she's a type 2 diabetic and she's well controlled on metformin. Would you like to continue or you switch out to insulin in pregnancy?
I will, depends on the sugars, but the sugars which you
well controlled. This not this patient. Suppose she's well controlled.
Well controlled. I can continue up to 12 weeks or so and then monitor. There is no contraindication to continuing with metformin, but definitely she may require insulin.
Most of the time they require insulin. Perfect.
Yeah.
So the types of insulins which are available, what are the insulins you use, ma'am?
We use only either the regular insulin, or we use the premix NPH and regular at 70-30, or we use the long acting, which is again we can use it sometimes.
Are there any particular indications for using this type of insulin or the other type of insulin? Do you have any?
We can use where we think that she needs immediate control of sugars. Definitely we will try to use the rapid acting, and if we have time we can use the intermediate acting or NPH or
so your management depends on the gestational age.
Management depends on the gestation, management depends on the sugar levels, and management depends on the monitoring which we are doing. If she's admitted, definitely we can give. And subcutaneous multiple dose insulins we can give, and of course we can give infusions also. Sometimes we have given when the sugars are very, very high.
No, what are you very
Charmila, but we are getting many messages saying that it's getting late. So I think you can reply to that, and maybe we have some concluding remarks from your panelists.
Okay.
Sneha, I think people are also asking to have a separate session on insulin.
I know.
Because it is normally if we refer
that we are doing every time, very focused sessions. One for GDM, one for ICOG.
So don't take away my time, Sneha. I'll just finish up. So the regimes which are advised is pre-mixed conventional, the basal bolus regime, the split mix regime, that is a twice daily regime where you add your NPH with a regular or rapid acting insulin. And if she is a type 1 diabetic, which is not controlled with your insulins, it's better if you go for an insulin pump based on an endocrinologist's opinion. And the conventional regime which we use is you start with a total daily dose where you calculate depending on the mother's weight, 2/3 NPH and 1/3 short acting. So the before breakfast, it will be 2/3 and before dinner, it will be 1/3. And you can actually, based on her sugar levels, you can actually increase or decrease, as Dr. Vijayalakshmi ma'am also said. Remember the newer formulations like Lispro and Aspart, they are actually very good compared to a regular the rapid acting insulin because they've got a short duration of action. So unexpected hypoglycemia do not occur when you give Lispro compared to the other rapid acting insulin. Then there's something called a long acting analog like the Glargine and Detamir, which mimic the basal body secretion of insulin. So you will not have those unpredictable spikes which you have with your NPH, which will not happen with your long acting insulin analogs, but this you have to do it with an endocrinologist's opinion.
And I think with the insulin pens that we have now, it is very easy for the patients to take that. And we can easily teach them like how to take and how to calculate. If it is syringe, then insulin syringe.
No, I'm talking about the regimes, ma'am. It's not the ease of injection, which is usually done with the pre-filled ones, which is very easy to use. But let me just tell you about the basal bolus regime with a rapid acting insulin, which is very good. You give a long acting, it does not have a peak at all. Basal level will always be maintained throughout the day, and you can control the spikes in between with a short acting insulin. And there they use Lispro or Nova Rapid, which is very simple to use. So I'll just put up that picture. The basal bolus regime is you give the long acting Detamir and it goes on acting the whole day. You give a single dose in the morning, and then the spikes in the middle you control with your regular short acting insulin, which will maintain it. And the next regime or split mix regime is same thing. You give only twice a day, breakfast and before dinner. So that will be like 7:30 in the morning and 5:50 in the evening. So in the morning dose, you give a regular with NPH, and at the 5:30 level, you give another regular with NPH, and it maintains throughout the day. This is one easy regime to follow during management of diabetes and pregnancy. And the RCOG actually has come out with something called an injection iPort Advance, where it's put already and it's not painful at all. It itself will release the insulin as per the patient's need. And Tabassum, what are the targets of therapy? 1 or 2 questions will finish, Sneha. Targets of therapy, we have already talked about it. I think Dr. Umayal mentioned that 100 and 140. I think it should be 90 and it should be
95.
120.
And according to RCOG, less than 95 fasting, 1 hour postprandial 140 and 2 hours postprandial 120.
120, perfect.
But I would also like to add one thing in this, that sometimes what we see is some patients do have FGR also. So there are few studies which are coming up, where they are studying that if the AC, abdominal circumference, is more than 75th centile, then we can keep the target as 80 and 120.
No, let's not confuse the audience, Tabassum, then nobody will follow. They'll all send it to a diabetologist. So we'll have it very clear. 95 fasting, 1 hour if they are doing it will be 140, and if they're doing 2 hours, it will be 120. Dr. Sarita, do you use the continuous glucose monitoring? Are you familiar with that, Dr. Sarita?
No, we are not using, but of course we are like aware with the devices which can be fit into the arm, and that gives us a continuous glucose monitoring. And that this machine works for 14 days. So that can be advised, but there are lots of controversies regarding the reading of this and matching with your actual blood glucose level.
Actually,
so
more than
usually during pregnancy, initial phase of insulin therapy, when the women want to take the insulin at home, to start with this device can be given. It can be giving you a rough idea about that, how her sugar is being controlled with that.
Counseling becomes easier when you use this device and show her how her time in range is, how many times her time is above range, and how many times it's below range. So that gives her a correct picture.
They don't write on the paper, they don't come with the diary. On that case, if you put this device, at least you have in the last 14 days recording. On and you can rely on that and adjust the insulin doses.
Actually, continuous monitoring, continuous monitoring of the blood sugar actually helps the patient realize that she's not taking care of herself properly. So she will come and listen to us. So in that way, continuous monitoring in the start of the treatment is very, very helpful for the patient. And once the sugar is under control, then we can ask her periodic evaluation of her sugar levels.
Okay, this question we've already answered in the chat box. So I'll just ask you, how will you manage her during labor?
Manages like if you have identified the GDM at a very early stage and her sugar is well under control.
Not GDM, she's a diabetic pregnancy. Sarita Balarao has finished GDM. This is diabetic.
Fine. Okay. So now she's a diabetic and her blood sugar is totally under control and all the parameters of the fetus and the mother are going in the normal schedule. Then the pregnancy can be very well taken up till 38 to 39 weeks. And if there is no obstetrical and cesarean should be done only for the obstetrical indication. Otherwise, we can actually once the sugar is under control, the macros.
Don't mention that bad word cesarean at all. Everything is the bad word.
Only for obstetric indication, we'll have to do cesarean. Otherwise, we can very well allow her to go for normal delivery.
Now, how will you manage her during labor? She's in total. She wants a vaginal delivery. She's everything is clear. Like, how will you manage her during labor? I'm asking.
Yeah, actually, like once she's a diabetic patient, like probably on the day of admission, we will check her sugars and we will ask her to take her food in a lighter meals continuously. We don't ask her to starve or anything, and we reduce the insulin dose to half in my experience in our patients. And then the continuous fetal monitoring is there. And at the time of delivery, and we don't do too many PVs for this patient. And once at the time of
and we would probably add.
No, actually, you give them the previous day dose, night dose should be given, morning dose should be withheld, and once she goes into active labor, maintain her sugars around 100 milligram per DL. That is a magic number there. It's not 120, 140, 100. 100, and depending on that, the fluids will be given. It can be a ringer lactate, normal saline, or it can be dextrose depending on her sugar levels. But glucose has to be checked every hour during labor. Do not leave it because diabetic ketoacidosis is known to happen during labors. Manager, and if you're supposed you're starting on insulin because of high sugars, you should go at a rate of 1.25 units per hour if it exceeds 100. And Ritu, I'm sorry I didn't ask you much. Post-delivery care for this patient.
Yeah, so we are afraid of the post-delivery. One thing is the breastfeeding, and lactation failures may occur in puerperal sepsis also. And we need to take care of our dose of the insulin too, because the requirements are drastically going to go down. So monitoring and accordingly adjusting the dose. And of course, the breastfeeding has to be encouraged because these children are much more prone to become diabetic. So 3 to 4 months postpartum in order to prevent the childhood obesity and diabetes in the offspring, and to reduce the risk of type 2 diabetes and hypertension in the mother also. And of course, in the other, you need to guide them for contraception, the barrier, the long-acting reversible contraceptives, the progesterone only, and DMPA. COCs, implants, rings, contraindicated with any macrovascular diseases. And they need to come to us, do a postprandial, you call them after 6 weeks, then 6 months and a year, and they still need to come to you if they were uncontrolled or such diabetic, so that they do not end up into diabetes in the next pregnancy.
Yeah, thank you. Thank you so much. So I'll just conclude with that HbA1c question, which Sarita also asked. At the booking, you will always check HbA1c for all pre-existing diabetics because you need to know the risk for the patient. But continuing doing HbA1c in the subsequent trimesters is a question mark. It may not guide you much because, as Dr. Vijayalakshmi also said, there's a dilutional, there's a physiological change of dilution there, so it will not help you much. But suppose she's showing a high sugar, just not in the diabetic range, so you're putting her as GDM. Still do a HbA1c at a first visit because you need to know whether she's a pre-existing type 2 diabetes, because then the management becomes much more vigilant because you have to avoid complications, but do not routinely use for all your patients HbA1c again and again. Thank you so much, Dr. Lakshmi ma'am, Dr. Parag, Dr. Sarita, Dr. Sneha Buyar, and all the panelists. You gave such great inputs. Thank you so much.
On behalf of all the panelists, thank you very much to the entire ICOG team and of course, beautiful and very efficient moderators. Thank you very much.
Thank you, Shabila ma'am and Sarita madam. Thank you so much.
Thank you. Yeah.
So I'm also
Sumitha,
thankful to the whole
I'll just add
ICOG team for such a wonderful session and taking me as a part of this session.
Thank you, ma'am.
Charmila, I'll just
Especially Dr.
quickly add
Parag
one
and Hema Devakar,
sentence
I'm
here.
seeing it here.
Yeah, Parag wants to say. Yes, Parag.
See, if you remember, a few weeks ago, we had one ICOG Chai Pe Charcha where we had Professor Sheshaya as the speaker. And, what he has suggested is that why it is important to determine whether a patient is pre-diabetic or not, because 3 weeks to 8 weeks is the time when we can really adhere to strict monitoring of blood sugars. If we have a good glycemic control, then it is possible for us to break the intergenerational chain. This is what Dr. Anita Rajoria had asked. So, that's probably the sole reason why we all should be doing HbA1c to begin with, ideally preconceptionally, but then at least at the booking visit, because we can be on our toes.
Yes. Thank you, Parag. Can we go for a post?
The office bearer, Chamila, I think I take this opportunity to thank Sneha and yourself. And of course, the panel was really good, informative. Thank you all the panelists for being so patient and being with us till the end. And Sarita, the future secretary of ICOG, should I say, and Charmila, our VP-elect, both have done a fabulous job, of course, ably assisted by the panelists. Thank you.
Thank you, Parag. Thank you. I think we'll go to the post test. Huh?
Yes.
Yeah. Nilima, please
Yes,
put
ma'am.
the link. Please put
Yes,
the link.
ma'am.
Link. 10 minutes. All of you can have a cup of coffee or dinner.
But I just wanted to say, guys, wonderful session. I really enjoyed.
Thank you, ma'am.
Didn't put my video on, but I really enjoyed listening to it. Wonderful.
Thank you.
Great, Parag and Lakshmi. Fantastic work.
Sneha, can you discuss the answers? Whoever wants to listen can listen.
No, actually, Charmila, I just talked to Nilima. She said today we just display the posters, and tomorrow morning when we start the session, then you have to do. That is what she was talking.
Okay. Then we'll let them join tomorrow. Then.
Yeah, tomorrow we start little early, 15 minutes prior maybe. So
Okay.
we can do that. Okay.
Okay.
I just talked to Nilima, so she called me that tomorrow we have to do that. It's a recap for the today's program. So yes, Supriya, you can just give vote of thanks, and I think that should be all. It's too late.
Yeah. So now we have come to the end of the day 1 ICOG certification course, and it was wonderful. All the speakers were very good. So I start from thanking our FOGSI Chair, President Dr. Rishikesh Pai, Secretary General Dr. Madhuri Patel, then Lakshmi Shrikhande Madam, Parag Biniwale Sir, and Dr. Sneha, Dr. Charmila, then the other Pratik Tambe and Dr. Mala Srivastav, all the speakers and the wonderful panelists and the moderator Dr. Charmila and Dr. Sarita Bhalirao Gandhi, and then Dr. Vijay Lakshmi, Dr. Ritu Khanna, Dr. Sarita Agarwal, and all who were present here. And the talks with brilliant speakers of today. So I thank each and everyone from core of my heart. Today it was, and I really thank the ICOG technical support, Dr. Miss Nilima. She really worked hard, and all the technical support who really had a smooth program today. So, and I thank all the audience. The participants were more than 320.
Yeah. So according to the official information, the registration is around 500, and the live audience who were just, attending more than 340 at a time. So 500 plus registrations. That is according to Nilima, ICOG office.
Okay, so very good, and so thanks to all the delegates who will join and all the people who wanted the certificate course. Thank you very much. See you tomorrow again. Thank you, Parag sir. Thank you, Sneha ma'am.
Thank you all.
Thank you, Dr. Sneha.
Yeah, before discussing, let everybody know the rules when they get the certificate.
Yeah, so ideally in the beginning of the course only we have displayed the rules and regulations that you will be having the pre-test daily before starting the session for the day, and then the pre-test will be displayed for 10 minutes. There will be 30 MCQs, and then you will have the academic sessions, and at the end of the day you will be having the post-test assessment once again. Those who qualify for it, that means those who score more than 50% marks for this, will be qualified for the certificate. So you all have to attend all 3 days, and you have to attempt the pre-test as well as post-test assessment daily for consecutive 3 days. And of course, as I said, you have to qualify for the passing marks of 50%. With this, I wish all of you a very happy learning and best wishes. And I'm going to conclude this tomorrow as a recap for today's program, and we'll be having the answers for the questions tomorrow morning. So tomorrow afternoon, rather, at the beginning of the session. So once again, I thank all of you officially and formally. And I request Nilima to conclude the meeting. Thank you, all of you, once again.
Yeah, well done, day 1. We have a lot of expectations from you even in the future. And Supriya, good job as the MOC. It was difficult sitting at one place for almost 4 hours is a task.
Thank you so much.
Thank you so much. And for me, even welcoming everybody was not possible because we wanted to focus on the academic discussions. So formalities were at a little second place today. So once again, a hearty thanks to all of you for accepting the invitation and contributing to the academic sessions. Thank you so much, all of you. Thank you.
Thank you, ma'am. And all the best, Madam Sneha, ma'am, for your future.
Congratulations, Sneha and Supriya. And once again, Sneha, all the best to you for the sessions.
Madam, thank you so much. Thanks for your blessings always. Suchitra ma'am, thank you so much. I'm so happy you are here till the end of the session.
Yes.
Thank you, Suchitra.
Thank you, madam. Thank you. Good night. Bye-bye. See you all tomorrow afternoon. Bye.
Bye bye. Good night.